I welcome you all to this seminar on retroperitoneal sarcoma. We have some exceptional presence here today in the field of retroperitoneal sarcoma. We will try and organize our talk in terms of a multidisciplinary approach for retroperitoneal sarcomas. And overall, we have a list of invited speakers and panelists. First of all, we are very honored and delighted to have with us Dr. Marco Fiore, who's come all the way from Milan. He's the expert sarcoma surgeon in the Istituto Nazionale di Tumori in Milan. And he has been very active and instrumental in the major changes in the way we manage retroperitoneal sarcomas. He's been a very active member and actually one of the founding members of the France Atlantic Retroperitoneal Sarcoma Working Group. And so there is a lot work going on in the fields of retroperitoneal sarcoma surgery. There is a lot of new knowledge that is generated from the center in Milan, and Dr. Marco is one of the major contributors in it. And we are thankful for your presence today, Dr. Marco. Dr. Nasiruddin is the pathologist. He has graduated from National Medical College and has done his pathology residency from Shah World Hospital. His sarcoma experience has led him to 3 months attachments in the clinic as well as in my sister. He's one of our the go-to sarcoma pathologists in Karachi. Thank you very much, Dr. Nasiruddin. Dr. Tariq Siddiqui is a professor of medical oncology in Zagreb University. He's one of the most senior medical oncologists, and we are always honored for his presence and his comments and guidance. Dr. Fahad Harun is a radiologist. He is works as a radiologist in Karachi X-ray, and he's also the director over there. He's also a local consultant radiologist in Women's Hospital in the UK. Dr. Bilal Qureshi is a radiation oncologist at Ahmad University Hospital, and he has a special interest in sarcomas. His main areas of work are pediatric and GU, but he's also the research person for adult and pediatric sarcomas at Retroperitoneal. We have other panelists, other members in our audience. Dr. Kampino is a medical oncologist. Dr. Samira Anyazi is a surgical oncologist who is a great help in managing our cases. Whatever efforts we do, he's a part of that. And I would like to also kind of inform about European School of Soft Tissue Sarcoma Surgery that has been established a few years ago by the community of, so this committee of CTOS, the Committee of Soft Tissue Sarcoma Surgery, and the European Society of Surgical Oncology. And their objective was to kind of standardize and have structure to training and how surgery is performed for soft tissue sarcomas. And they've been quite instrumental, I think. The first batch will be graduating this year or being certified later this year. And we have the honor Dr. Marco Fiore is actually director of this School of Soft Tissue Sarcoma Surgery. With the tail, we have had the initiative to set up a better service for soft tissue sarcoma, and we identified Dr. Famina as the lead person in limb and truncal soft tissue sarcomas, and myself managing distal and retroperitoneal sarcomas. And we are always grateful for the support that we've received from the team in Milan. So Transatlantic Oscillation Retroperitoneal Sarcoma Working Group, which is the newer name for it now. This map is actually installed on a wall in the sarcoma office that Dr. Marco Fiore and Dr. Zonki shared. And we are happy to report that we have put Pakistan on the map of DARP's working group. So I think with this brief introduction, we will start off our session. I would invite Dr. Marco Fiore to give his talk on management on retroperitoneal sarcomas.
So thank you very much, Dr. Raza. I thank the hospital and Dr. Raza for inviting me today. I'm very honored and happy to be here. I'm coming from National Cancer Institute in Milan, Italy. We are referral centers in our country for soft tissue sarcoma. And what I would like to show you today is what has been changed in the last 15 years in the treatment of retroperitoneal sarcoma. That is sort of minority of cases in soft tissue sarcoma. They account for 15% of cases, but the treatment is much more challenging from the surgical standpoint and also from the outcome standpoint, because usually it's considered as a poor outcome. So we will focus today only on retroperitoneal tumors. You know that soft tissue sarcoma has a rare tumor, so we have in Italy roughly 400 new cases per year, and so this is one of the reasons why the treatment should be also centralized in specialized centers, not to spread out the experience and the treatment. Starting from the differential, the diagnosis, once you have a retroperitoneal mass on a CT scan, maybe found by chance, the probability to have a retroperitoneal sarcoma is not the major one, and you have always to keep in mind some differential that are very, very important, because as you can see, the CT scan may be can be similar, but the diagnoses are very different, and different can be the treatment of this kind of couple of diseases. Even in the case of mesenchymal tumor diagnosis, you can have some differentials between benign and malignant entity, like the angiomyolipoma can be easily differentiated with well-differentiated liposarcoma, as with myelopoma in the adrenal site. So this is to say that the preoperative biopsy is considered nowadays mandatory, so it should be always performed, and there are some robust data that allow you to perform a percutaneous biopsy as a safe procedure and an informative procedure. So no impact on outcome is expected if a patient receives a percutaneous biopsy. This is very important because sometimes it's believed that the risk of spread of disease or contamination or sealing is important. So if you take a biopsy with a posterior approach, with a coaxial needle, then it should be considered really a safe procedure. The importance of biopsy is not only for differential with the other tumors, but even between single entities in retroperitoneal sarcoma. Preoperative biopsy can give you information about how to inform the treatment, because we consider a different strategy if you have a very differentiated liposarcoma, a leiomyosarcoma that we will see afterwards has a very high metastatic potential, or a solitary fibrosis tumor that can be a very indolent tumor, can cure only with surgery, but surgery may be even more demanding for the vascularization of the tumor. So having this information before is very, very useful, even for the surgical oncology itself. We published some data on the accuracy of biopsy. So what I can tell you is that usually you are able to diagnose a mesenchymal tumor or a retroperitoneal sarcoma. There is a very good accuracy for leiomyosarcoma. What is lacking in sensitivity and accuracy is the differential between well-differentiated liposarcoma or a differentiated liposarcoma. This is also a problem of sampling, because the differentiated liposarcoma are are very are not homogeneous tumors, so you have to plan the biopsy in advance with the radiologist and just decide which is the part that you are interested to sample, not just the tumor, but the more aggressive, or likely more aggressive part of the tumor. In this sense, the sensitivity and the specificity between well-differentiated and dedifferentiated liposarcoma may be improved. Also, the predictability of tumor grade is good. The chance to overestimate the tumor grading on the biopsy is very, very low. But you should be aware that in case of liposarcoma, if the biopsy is not targeted on the high-grade part, then you have mostly 50% of chance to underestimate the tumor grade. This is also important when, for example, a neoadjuvant treatment should be discussed. So in suspected retroperitoneal sarcoma biopsy is safe and mandatory. This is my first message, and I think that is the first step to improve the quality of care in these tumors, because it can inform then the treatment. Because the most common pitfall, for example, in liposarcoma, if you don't have operative biopsies, is just to misdiagnose the well-differentiated component that, after a simple excision of the solid part of the tumor, is left behind. So this actually is a persistent disease, persistent primary disease, and this kind of surgery before and after should be considered not only incomplete, but also contaminated, because the surgeon has passed through the tumor has been open. So the chance to rescue this patient from a retroperitoneal tumor is becoming lower and lower. So these are the historical data that we know that the outcome is considered poor, with an overall survival of 30% in the major public series, and the local recurrence rate up to 50% of 5 years. So this is unacceptable. I mean, it's not the same that we see in extremity soft tissue sarcoma, in truncal sarcoma, and which is the reason. I mean, these are the same tumors, and usually, for example, in extremity, well-differentiated liposarcoma, that is the most common histology in the retroperitoneum, has a wonderful outcome. You don't expect any patient to die from a well-differentiated liposarcoma of the calf or the arm. It is the opposite in the retroperitoneal side. So we ask ourselves why, which is the reason, what can we do to improve the outcome of this patient that has the same disease but a different and more challenging style. The other difference between extremity soft tissue sarcoma and retroperitoneal sarcoma is that 75% of patients will die of local disease. This does not happen in the extremity. So local control is the key point. If you have a local recurrence, then the patient can die of local disease. So what we consider and what has been changing this year is a shift between the simple excision of the tumor, that was the normal approach of general surgeon to this kind of big and huge abdominal mass, versus an extended resection. Extended resection that is mutuated from the surgical philosophy program of the extremity tumors. So nowadays the basic principle of surgery is to remove, obviously, all the tumor. This is not automatic. I'll show you an example. So you have not left behind anything, avoid the tumor rupture in the surgical field, and take it out surrounded by the cuff of healthy tissue. That in the case of abdominal mass can be also some organs around the tumor. So this is a therapeutic challenge, because the space, the anatomic space, is complex, it's difficult to approach, and there are also some vital structure at variance with the extremities. So are we able to apply this principle in the abdomen? So to give a wide excision that is the standard for extremity sarcoma, and not a marginal excision of the tumor.
it is so important? Because we know that if you have a planned positive margins, this is the series of extended sarcoma published by the Canadian group. Okay, the best outcome is with negative margin, but if you have limited positive margins on critical structures, then the outcome is quite similar to the negative margins. While if you have inadverted positive margins, the outcome is poor. So if we cannot apply exactly the philosophy of wide surgery in the abdomen because of the anatomy, because there are no barriers in the abdomen like in the limbs, at least we can try to reach this cure. So the cure of minimal, limited positive margins over a 40 centimeter mass, for example. So the aim is to minimize marginality. So this, we published this series some years ago, analyzing what we obtained before 2001 and after 2001, when we tried to shift from a simple excision to a wide resection, a more aggressive approach. And actually what we saw is that we increased the number of organs resected and blocked with the tumor. So half of the patients received the resection of 2 or more organs. Now we changed this number. Now we are around a median of 3 to 4 organs resected and blocked with the tumor. So things are changing. And what we obtain is that comparing the early series with the recent series, we obtain a reduction, significant reduction in local recurrence. So this is the first evidence, and by chance this article was published in the same issue of the journal with another study from Dr. Bonvalot in Paris that I visited for some time before 2001. So we exactly changed together the approach. She analyzed in a different way her series of distinguishing compartmental complete resection, that was this extended approach to simple resection, and she obtained the figures that are quite similar. So we had 2 different independent evidences, retrospective evidences, that an extended approach could have been a key point to ameliorate the local control in retroperitoneal tumors. This has been criticized because it was retrospective, there was no evidence, it could have been biased, and most of all because it was data on local recurrence. So there was not an evidence of overall survival, but we had to wait some more years to have longer follow-up, and finally we demonstrated that the better local control obtain better survival. So there is the chance, significant chance to obtain 18% of better overall survival at 5 years. That is not negligible. So we talk about this extended resection and the aim to minimize marginality. We deal with mostly 4 kind of histologies. I think we will talk about this later. So essentially we have the liposarcoma that we distinguish in well-differentiated, dedifferentiated, but even between the dedifferentiated it is important to grade the dedifferentiated part. So we distinguish between the differentiated sarcoma of the intermediate grade G2 and high grade G3. Then we have the leiomyosarcoma and the solitary fibrous tumor. There is a minority of other histologies that are much rarer, and the treatment of which is very, very different and depending on the single histology. So I ask you to consider this apart from the general treatment of liposarcoma and leiomyosarcoma. So the natural history of these 4 diseases is very, very different. A well-differentiated lipo and solitary fibrous tumor has the better outcome. This is a series of more than 1,000 patients that we obtain putting together the data of the major centers of the transatlantic collaboration that Dr. Raza talked to you about. So the overall survival is the better for well-differentiated and solitary fibrous tumor. The differentiated liposarcoma and leiomyosarcoma fare worse. But the reason is different because all the subtype of liposarcoma has a very high chance to have a local recurrence, while only leiomyosarcoma and high-grade, the differentiated liposarcoma, have a high chance of metastatic disease. So you have, after diagnosis, you can inform the patient of the single risk. So if the risk is higher for a local recurrence, there is a local problem, and surgical oncology should be as much aggressive as he can. But if there is also a high metastatic risk, you should consider maybe a multimodal approach, or you can consider to limit the extensiveness of resection, because the major problem for the patient will be the metastatic risk. So it's not nonsense to offer so extended multidisciplinary resection for a disease that has highest risk of metastatic spread than local recurrence. The problem are the high-grade, the differentiated liposarcoma, where both risk of local recurrence and metastatic risk. So the extended resection has a rationale also based on the microscopic invasions of the surrounding organs. Even if they seem very capsulated organs, they are not. And we found organ involvement up to 60% of cases. But this organ invasion can be of the viscera, but can be also of the pericapsular, perivisceral invasion. For example, the pericolic fat or the peripancreatic fat or the fat tissue of the mesentery can be microscopically involved. So this is the strong rationale behind the idea of extending the resection to surrounding organ. How can you rate the risk of a patient? There are some nomograms that are very useful in the clinic to rate the risk of the single patient, and we also develop an app that you can freely download on your smartphone, and it's very useful when we discuss this patient in the MDT. So we can shape the treatment according to the risk of the single patient. So even after the comparison of this transatlantic sarcoma group collaboration of more than 1,000 patients, we confirmed the survival advantage over the population-based series of the SER registry, and the range of advantage is exactly the same of our previous series. So the survival advantage is in the range of 20%. So the number of retrospective, sorry for this, but this is a rare tumor, so it's very difficult to obtain prospective data in large series. But the number of retrospective evidences is increasing, and they are coming really robust and consistent. The other important message is that this kind of approach is a one-shot approach. So once the patient has recurred, this is the analysis of the transatlantic group. Once again, we analyzed the post-relapse outcome of our patients. Once the patient relapsed, then the outcome is dismal. Whatever is received, whether he receives surgery or not. Surgery can delay the post-relapse survival, but the slope of the curve has not reached any plateau, so he will recur anyway, and the rate of second local recurrence is very, very high. So you will have the chance to cure the patient at the beginning. First operation is crucial. Okay, first operation is crucial. This is the law for retroperitoneal sarcoma with the corollary that any recurrence is virtually incurable. Okay, so this is the second key message I want to give you. So for surgical oncologists, I will show you some stages of the procedure. It has been named in the literature like compartmental resection, aggressive surgery, extended resection, multivisceral resection. So you can find all these names for the same procedure. And the idea is just to resect the ipsilateral kidney and colon, and on the left side the distal pancreas and the spleen if the tumor is up to the level of the transverse mesocolon, while the major resection like pancreatic duodenectomy or hepatectomy or vascular resection is performed only if there is evident macroscopic invasion. So we don't give up in that case, but we offer this even more aggressive procedure only in case of macroscopic invasion. So this requires many surgical skills, like general surgical, it's a major procedure of general surgery, major GI and HPV procedure, major vascular surgery. You should be trained in muscular resection or reconstruction. You should know the anatomy of the nerves of the retroperitoneum that is not obvious for the general surgeon, okay? And you have to deal with the high variability of anatomic presentation. So we try to categorize and stage this procedure systematically. So first of all, the approach to incision is not minimally invasive, okay? So we have because you have to be on the safe part. So there is a wide midline that can be also extended on the transverse or subcostal side, or you can have a ilioinguinal incision if you need the vascular control on the iliac axis, or even a thoraco-abdominal incision if the lesion is invading the subdiaphragmatic region. So then we try to expose at the best the field. This is a tumor who was extending from the retroperitoneum to the thigh through the groin. And then we have these kind of stages. So on the right and on the left side is a little bit different. So first of all, the exposure, I told you. Then the first stage is the division of the right colon or the left colon on the median line, and the assessment of the pancreas and spleen on the left side according to the level of the tumor. The second stage is the Cocker maneuver for the right colon. So the duodenum is moved from the lesion, and on the left side you have to mobilize the splenopancreatic tissues. Either you can choose to resect the pancreas if the pancreas is overlying the lesion. The first stage is to dissect the major vessels. So on the right you have to dissect the vena cava and the aorta. This is a key point because you can say that this is margin on the vessel, but you have to dissect the vessel under the adventitia. So the adventitia is very subtle, but this is a barrier. We use this at the barrier in the surgery of the extremity tumor. It's the same for the abdominal tumor. You keep the adventitia on the critical margin on the vessel. Then you go laterally and you keep the peritoneum, lateral peritoneum as a margin laterally. And you resect the rectum on the left side. And you resect the psoas distally. So the psoas is kept on the back of the specimen. The fifth stage is the section of the origin of the psoas on the vertebra, on the column, on the spine. And finally, you have to prepare the costodiaphragmatic fold on the upper part of the tumor, and sometimes you have to resect also the diaphragm if the tumor is invading the diaphragm, or sometimes only to allow a more safer maneuver and to avoid tumor rupture. So sometimes the diaphragm is free, but we decide to open the diaphragm, to put a hand on the thorax and pull down the specimen to avoid to have tumor rupture on the posterior part. And finally, the tumor resection. So this is a schematic resume of the procedure. So we call the classic right RPS, classic left RPS. And today this should be considered a standardized standard approach. It is standard because it is now recognized also in the European guidelines as the best approach we can offer to primary retroperitoneal tumor, localized retroperitoneal sarcoma. We analyze also the morbidity, surgical morbidity. This is an acceptable procedure in the referral centers. The rate of G3 complication is around 18-20%, like in major surgical oncology procedures. And the risk factors are the age, so this risk of morbidity is increasing with the age. It is increasing with the number of organs resected, that is a proxy of the complexity of the procedure. So the classic standard has 3 or 4 organs, according to the right or left, but more than 4 organs it means that the procedure was more complex than expected. The tumor was more extended, so the risk of morbidity is increasing as well. So Dr. Raza already told you how we collaborate in the last years with the international community, and I just want to show you how did it work. So we start to have wet seminars of live surgery together with the French group in Paris. So we, for some 4 years, we organized live surgery with all the experts coming from Europe and North America, and we share the experience operating together just to start to speak the same language one each other. And we found this collaborating group, this spontaneous collaborating group that has been born within the Connective Tissue Oncology Society, that is the scientific society that has the most important annual meeting on soft tissue sarcoma. This is an initiative by the surgical oncologist of the group interested in retroperitoneal tumor, but we involve also the other professionals like pathologists, radiologists, radiation oncologists, all the people interested in retroperitoneal sarcoma. The group was growing in the last years, and we had some, it's so growing that we had to change the name between transatlantic and now it's transatlantic Australasian retroperitoneal working sarcoma group. And we had many initiatives together. The most important was the successful accrual of the first ever randomized control trial on preoperative radiation therapy in retroperitoneal sarcoma, the STRAS trial that has been closed and will be, the results will be communicated in next ASCO meeting this year. And other initiatives are a number, okay, we have a website if you are interested in, and the other initiative is a number of papers in which you can find the guidelines agreed from among experts worldwide on the treatment of primary tumor, treatment of recurrent tumor, treatment of metastatic tumor, morbidity, and so on. Okay, all these items were covered by consensus papers by the group. Also radiation therapy in liposarcoma is the last paper published this year. Another initiative that is running presently, and I'm involved in this project, is the prospective registry of all primary sarcoma operated in referral centers worldwide. So we are recruiting today in 25 centers worldwide, big reference centers, and we were able to accrue in 1 year and a half roughly 600 patients today. These are data from last November. So I told you that the 1,000 patient paper, retrospective, multi-institutional retrospective paper was the largest series published. It covers a period of 20 years. Okay, now in 1 year and a half we recruited 600 patients. So the potential is impressive of this instrument, and I warmly invite you to join this initiative that is open, is collaborative, is spontaneous, and so in some years we will have some more robust and prospective data on this disease. Dr. Raza already told you about the initiative of the European School of Soft Tissue Sarcoma Surgery. That is another initiative to improve collaboration and spread knowledge and to improve the treatment of this kind of tumor in the community of surgical oncologists. So collaboration is the key point for making progress, and this is a quote from Charles Darwin: "In the long history of humankind, those who have learned to collaborate most effectively have prevailed. So I hope this will be the same for surgical oncologists and for surgical oncologists interested in retroperitoneal sarcoma. So this is my conclusion. This is the complex surgery, but it is still the keystone for cure of this disease. The primary approach is crucial, and we need an aggressive surgical resection to improve local control. The aim is to minimize the marginality if negative margins cannot be achieved, but this makes the difference. And treatment should be tailored to histology, so systematically extended to adjacent organ in liposarcoma, a little more conservative for leiomyosarcoma for the metastatic risk, and in solitary fibrous tumor for the low risk of any local recurrence. Morbidity is acceptable, but you need to be able to anticipate the risk factor to be on the safe part, and the best come is at reference centers documented, so it's really, really important to be, to manage these tumors in a multidisciplinary setting. So I'm open to any question, or I don't know if you Dr. Raza, want to postpone the question and answer.
No, I think we can take questions now. Are there any questions from the audience? We're happy to say that we have some active audience for the live stream as well, and there are some questions from there. I just asked the question that Dr. Hamad Khan is asking that in high volume soft tissue sarcoma expert institutions, what are the features that suggest irresectability?
So irresectability is mainly evaluated on the involvement of not the major vessels, but the celiac axis, the superior mesenteric artery. So these are the normal, I would say, irresectability criteria for abdominal surgery. So we don't consider irresectable a tumor who is invading the vena cava. You should know that sometimes, for example, the leiomyosarcoma often arises exactly from the vena cava, so the vena cava can be sacrificed. It is not irresectable if it is invading the aorta. The problem is to judge the irresectability when the tumor is extending beyond the retroperitoneal space. So it could be extended in the thorax, in the parietal wall, thoracic wall, in the groin, in the back. And this is more challenging, but not formally irresectable. You should be aware that the chance of local control is less than the normal presentation. The other criteria of irresectability could be the invasion of the foramina on the colon. We perform also some en bloc resection with hemivertebrectomy, but this is a very, very morbid procedure. We never did it without a preoperative treatment, either chemotherapy, but mostly radiation therapy, because when the psoas is highly invaded and the tumor is very close to the spine, we just consider to give radiation therapy before to improve the quality of margin of the very, very critical side that is the colon. So in conclusion, the irresectability criteria are the involvement of the SMA and the tripod.
Taking the same line onwards, there are some who would say that even if you can't completely remove the tumor, you should debulk it to improve symptoms as much as you can. How do you feel about that approach?
I disagree with this approach, even because I have to be consistent with our consensus. So you will find a consensus on the treatment of primary and also the consensus of treatment of metastatic disease. There is no evidence that the bulking procedure can be of any benefit from outcome point of view, and you should be aware that you cannot palliate a patient that is asymptomatic. So sometimes these diseases are very, very extended and huge, but the patient is still asymptomatic. So in this case, any kind of even partial resection cannot ameliorate the quality of life of the asymptomatic patient. On the contrary, it could be the cause of many surgical complication, for example. So debulking is not useful from the oncological point of view. It's not useful for palliation in asymptomatic patients. So when we consider debulking, it's just only in the case of recurrent tumor or metastatic tumor that becomes symptomatic, but not symptomatic to cause, symptomatic for abdominal complication. Otherwise, they are candidated to medical therapy. They are effective drugs, even in terms of palliation. And so if a patient gets a bowel obstruction for a progressive metastatic disease, then you can consider the palliation not of the tumor, but of the bowel obstruction.
And taking this same idea forward, that majority or a large proportion of these are well-differentiated liposarcomas. And they're generally local disease with a very small risk of metastatic spread. Organ preservation, I mean, some people would argue that, performing a very aggressive upfront multivisceral resection, taking the kidneys out, leaving them with one kidney, versus taking just the tumor out, shaving it off the kidney, letting this patient live with the kidney for some years till the tumor comes back, and maybe at that point in time. So a second surgery in which if the kidney is involved, it can be taken out. How do you feel about that?
Yeah, thank you, Raza, because this is the question that we had for 15 years. So even between experts, there was a very hard debate about this, how to deal with low-grade tumors and aggressive surgery. But I show you the data. So first treatment is crucial. You cannot expect the local recurrence, but then you cannot rescue the patient anymore. If the patient has a low-grade tumor, then he has the best chance to be cured. But the price to be paid is an extensive procedure. Why? Because anyway you will have microscopic invasion. Even if the kidney is macroscopically healthy, then it has some microscopic invasion, at least at the level of the pericapsular fat, perirenal fat. So in the long run, this is not benefit for the patient. Moreover, we demonstrated that the quality of life and the risk of long-term disabilities in this patient is low. So the morbidity is acceptable. They can have a very good quality of care, quality of life. The renal function is preserved. Okay, so we calculated if the patient is operated with stage 1 or stage 2 chronic kidney disease, then he expected a 30% reduction of the renal function. That means that at least he can reach stage 3. But we have no patient who were in dialysis because or an end-stage renal disease because of the monolateral nephrectomy. You perform monolateral nephrectomy for any renal cancer, no? And the patient, there's no problem of renal function in the long run. Why should be different for... We were also able to give any kind of needed chemotherapy to patients who are with a single kidney. Even we were able to give ifosfamide, that is an active drug, in the liposarcoma setting, and medical oncologists are often scared about the renal function if you give ifosfamide, but we were able to give ifosfamide to our patient anyway, because I told you that they are stage 2, stage 3 with the renal function at that time.
Can I ask a question? Is there a difference between well-performed surgery leading to recurrence and then the outcomes are the same, or if you, as in the most of the world, you have badly performed surgeries, then if you do a resection, is there a difference in that given the time elements?
So we look at the study in our international collaboration, and what we found is that if you offer a second surgery at a referral center for mistreated primary, so you have persistent disease or a first recurrence after so-called inadequate surgery, then you can somewhat rescue the patient, but not at this stage, not at this level. While when you experience a local recurrence after an extended resection, then the outcome is very, very poor. So this means that the local recurrence is expression of very aggressive disease, and the biology of the tumor is overcoming the extension of this kind of resection. Sorry, the rate of second surgeries in the local recurrence after primary treatment at our centers is as low as 25%. So 1 every 4 local recurrence of our patients can be operated. Otherwise, the treatment is medical therapy or radiation therapy or best supportive care.
Which patient would you consider for downstaging if they are primarily unresectable? And what strategy? And does it work?
Yeah, so we have a new adjuvant, very effective strategy for leiomyosarcoma. There is a number of drugs that are very, very active and effective. So we don't use ifosfamide in leiomyosarcoma. We use obviously anthracyclines, but anthracyclines can have a doublet with the dacarbazine, for example, and you can have wonderful downstaging. For example, we use for advanced inferior vena cava leiomyosarcoma. Sometimes you can judge irresectable because it reached the level of retrohepatic or suprahepatic veins, and you can obtain a wonderful response. You can also combine chemotherapy and radiation therapy in this situation. For liposarcoma, you should not think about neoadjuvant treatment as a downstaging, because we have active drugs, but you cannot obtain a dimensional response. So, for example, the experience from Strass trial is that if you irradiate the liposarcoma, whatever well differentiated or the dedifferentiated, you will not obtain a major dimensional response. But it is not the point, because also in the extremities, the aim of neoadjuvant treatment is not primarily cytoreduction, but is to ameliorate the outcome. So in case of liposarcoma, we consider a neoadjuvant treatment. In case of high-grade dedifferentiated liposarcoma, if it is demonstrated on the biopsy, then that patient is at risk. Moreover, you have some patient with high-grade dedifferentiated sarcoma with systemic symptoms, fever, weight loss. So these are the very bad patients. So we offer first chemotherapy and afterwards surgery. That would be the same procedure that at the first line, at front line. Okay, so we do not obtain a downstaging, but the patient is offered to have something more than surgery that will be not sufficient to give the best option. The other thing we consider radiation therapy, for example, in pelvic tumors. It is a little different. They are not really the retroperitoneal sarcoma, but in the pelvic region, radiation therapy can ameliorate the margins that the space is more closed. There are more critical structures. So in that case, radiation therapy can offer better minimal negative margins.
If you're convinced that you're going to get an R2 resection,
sorry?
If you are convinced you're going to get an R2 resection, should you even be operating?
No. No. So this is a very rare situation. Okay. In our experience, so patients who are considered irresectable at the beginning is a minority, less than 10%. In that case, I would not go for surgery frontline. I would try any kind of preoperative treatment, otherwise non-surgical treatment.
I think thank you very much for that, because there are oncologists who push surgeons to, like they said, default or just take it out as much as you can, and it doesn't work.
No, I agree. That doesn't work. I absolutely agree.
So, like we know for limb sarcomas, if um, inappropriate or inadequate, let's say oncologically inadequate surgical resection has been performed, a salvage surgery can be done for limb sarcomas especially.
Yes.
Why is it not the case in retroperitoneal sarcomas? Especially when the vessels are not involved or the resectability.
Yeah, it is not the case. So first reason, we have no data. So we are trying to find some data on this. So there are no data, so this is not a standard treatment that can be offered. But second reason is that the situation is very different. In extremity, you have some anatomic compartment. So you can think that if the surgery was inadequate and contaminated, you can remove all the compartment and then you are on safe margin anyway. Then you do not perform a compartmentectomy anytime you go for wide surgery anyway, but the idea is to have some barriers on the tumor bed, on the surgical bed. In the abdomen is not the same. So I show you the approach is a very wide midline. So just opening the abdomen, you violated the compartment of the tumor. So you pass through the peritoneum. The peritoneum is violated after first surgery. And for this reason, a second surgery it should not be considered just like the same in. We try to do this kind of re-excision of after simple surgery. We demonstrated that it is feasible. We had a higher rate of complication actually. We found anytime some microscopic tumor remnants, especially in liposarcoma, but we were not able to demonstrate that you can rescue the outcome of patients. So presently we consider this option on an individual basis, discuss it with the patient, but this cannot be considered as a standard approach. We are trying to design a study, a protocol, and it's very difficult because it's so my point is not, we have not to demonstrate that the second surgery can rescue the patient. We have to optimize the referral of patients so any patient can receive the best surgery at the beginning. This kind of re-excision should not exist even in the extremities.
So it's an online question by Dr. Muhammad Asif. Why recurrent disease cannot be resected, especially if it is not involving any major vessels?
It can be resected, but you cannot obtain local control anymore. So you can operate the patient, okay, but then the risk of have a second local recurrence it's very, very high. So patient can be operated. There are patients who the natural history of disease for some well-differentiated sarcoma is very, very long. They can receive 3, 4, 5, 8 surgery lifelong. But finally he will die of local recurrence. So I'm not saying that you cannot operate the patient anymore. I'm saying that you cannot cure the patient from this disease anymore. And I'm asking you whether it is better to survive with less organ and only one kidney, or to die with all your organs and 2 kidneys. So.
Yeah, when you said that psoas has to be taken down at its origin, is it across the board or is it in the patient enough to get a wide margin on the psoas rather than taking it down at the origin every time?
So taking out the psoas from the origin doesn't mean that you resect all the psoas. Okay, from the origin it means that the psoas should be detached from L2, L3, L4, L5. Okay, so you have some muscle all over the tumor. But if you start to resect the lateral part of the tumor, then you have to detach the origin of the lateral part from the spine, and you leave the lower part that is originating from L4, L5, and it's covering the femoral nerve. So finally you have the coverage of all the specimen on the back But to do this, you have to reach the column. So you go straight from the mesocolon to the vena cava and then to the vertebral bodies. And then there you will find the origin of the psoas, the upper origins of the psoas. Okay? So you have to touch this. I have some picture maybe.
Just this will go back.
So the psoas is starting here. So if you detach the lateral part, there are some psoas left that is covering the nerve, but you have to reach this point. Otherwise, the tumor is uncovered.
But for smaller tumors, you can stay in the meat of the muscle and not have to do that.
Yeah, you can stay in the middle of the muscle. But if you go proximally, the middle of the muscle become the origin of the upper part of the psoas.
But I understand that it's not a rule that you have to do it every time.
No, it's not. Well, it's a rule to have something behind the tumor, and something behind the tumor usually is the psoas. Okay. Then the quantity of psoas resection depends. I told you that there's a high variability. So we usually, in the classical situation, we detach half of the psoas. That means that it's all the psoas in the upper part and half of the psoas in the lower part. And this preserves the femoral nerve. But sometimes you need all the psoas, especially if the psoas is macroscopically embedded on the CT scan. So if I see that the psoas is embedded on the CT scan, this is done with the radiologist, and sometimes we ask also for an MRI if we are in doubt. Maybe we consider radiation therapy, and then we reset all the psoas exactly on the body, and then the femoral nerve is well prepared and preserved.
So, two questions regarding radiation therapy. So, first by Dr. Hamad Khan, what percentage of patients got radiation with the retrospective studies? I think it's mentioning mainly the SEER database. And if yes, was there any benefit on overall survival? I think you've touched on that, but if you could briefly go through that.
Yeah, you can find this data recently published by Dr. Haas, who is the radiation oncologist in Amsterdam. So the rate of patients who receive radiation therapy out of the study is very, very variable, and it's really dependent on the institution. You know that the Canadians people have a long tradition of radiation therapy. They irradiated the majority of patients, also in retroperitoneal sarcoma, more than 60%. In our center, it was between 18 and 20%. So presently is not a standard. What the consensus says is that if you want to consider radiation therapy, you should do it before surgery, because after surgery the toxicity is unacceptable. According to the outcome, it's on the retrospective analysis, it seems that there is some advantage for low-grade liposarcoma, but we cannot base on this retrospective data. They are completely biased. They are hypothesis generating, so we will wait for the prospective data of STRAS that are coming in the next months, even if they will be not concluding, because unfortunately the study was not designed to distinguish between histologies, so this will be an issue in interpreting the data. But otherwise, this kind of prospective randomized trial would have not been feasible. So we accepted a compromise in the study design to reach the accrual that actually failed. In the US, they tried twice to run a randomized trial for radiation therapy, and they failed with accrual, and we succeeded with this kind of international, spontaneous, generous, and non-profit collaboration between our centers.
And Dr. Faraz Khan, I think this is Dr. Faraz from Dublin, who's asked any role of intraoperative probe radiation therapy, especially after resection, to address the margins?
There are no data on the efficacy and outcome. There are some data from a Canadian study, actually, of unexpected, very serious morbidity after boost with intraoperative radiation therapy, especially for duodenal fistula. So presently there is an alert in our consensus that consider that intraoperative radiation therapy could be a reason for very, very serious complication. And on the opposite, there are no data on the oncologic outcome.
And what about use of intraoperative indocyanine green to assess margins at the time of resection, or just looking at it is enough?
I have no information on this, but I would say you need a leader of indocyanine because you have big mass. So no, we have. This is a good idea. We should study some kind of intraoperative evaluation of margin, but this is very, very difficult, even if, because we are not able to ask for frozen section, for example, because frozen section for a lipomatous tumor is not feasible and is not reliable. So actually, presently, the extent of resection is decided preoperatively based on the multidisciplinary discussion, and the decision to resect an organ is a priori, so whatever is the infiltration, according to the extent of disease and the subtype of disease. So it's very, very rare that we change our plan intraoperatively. Obviously, it is verified, but usually the decision to resect an organ or not is made before surgery.
Have you discussed what is the adequate margin for the sarcomas?
So what are the adequate margins for retroperitoneal sarcomas?
So our adequate margins are complete resection. We consider this kind of surgery by definition R1 resection. So you cannot imagine that this kind of tumors, even if you extend this surgery to the surrounding organs, will reach R0 margins because it's a bulky lesion, you have no barriers. Okay, so we consider R1, whatever is the extent.
But R1 is a positive margin.
Yeah, microscopically, yes.
So if you're saying negative margin, how much distance should be at least for the negative? 0.5 is also negative margin, 1+ centimeter is also.
So the definition of R0 is no tumor within 1 millimeter from the ink. But I don't mind if the retroperitoneal sarcoma, I don't mind if the margin is R1 or R2 or R0, okay? My aim is not to have R2. So all the analysis on outcome are made distinguishing complete resection and incomplete resection. And what you can see in the evolution over time is that the rate of complete resection is increasing in referral center with this kind of aggressive approach. But I think that the pathologists can answer this question. You cannot imagine to expect a pathologic report that this is an R0 resection, because it's not possible, it's not reliable. I don't trust that the pathologist will sample any single centimeter of a 13 kilos specimen. Okay, so if you receive a report that is R0, doesn't matter, it's not true. Okay, cannot be true. So what is important is that the tumor resection is complete. There is no remnant tumor. This is your, if you are a surgical oncologist, this is your responsibility to rate on the report complete resection, no tumor rupture, and then this can be verified with a postoperative CT scan. Okay, the information you have to ask to the pathologist is whether the tumor is high grade, low grade, the differentiated, so complete information of the biopsy, and to rate the invasion of the surrounding organs. But there is no standard reporting for R0 or R1.
You're saying that the IORT, intraoperative radiation therapy, that is not so strong for R1 margin, R1 section. If it's meant for the R1 section, the IORT must be done when you are when you are given the neoadjuvant radiation therapy, and then there is some R1 resection, where there is vessel involvement, there is bone involvement, you can't go further than that for that margin. Then aortic appetite 15, 16 grade goes to be 20.
No, there are no data on efficacy.
But they have shown this about benefit.
No data, no data. There are no data.
I think Dr. Bilal will address this question, and I think perhaps just having a layer of tissues around will help us. For example, if it is close to a vessel, having the adventitia, so that having that barrier around
So
the tumor is more important
you can
than
say
knowing
that
the size
the
of the
resection is R0 on the vena cava, but this is not an R0 section to occur, because in some point of the specimen it will be marginal.
So avoiding leaving behind tumor in critical areas and trying to take, for example, if it is liposarcoma, trying to take every bit of fat out from the retroperitoneum is probably the key.
Yeah.
I think,
Okay.
thank you very much. This was
Thank you.
very
Thank you.
informative. Thank you again, Dr. Fiore, for this very informative talk. I think now we will move on to the other aspects. Although a majority of the things have been covered by Dr. Fiore, but the remaining additional talks are a talk on pathology as well as a talk on radiation oncology for these retroperitoneal sarcomas. And the idea was more to present the local perspective, what kind of challenges we face in our setting in managing retroperitoneal sarcoma or diagnosing them. So I'll first invite Dr. Nasiruddin, who's a consultant histopathologist at the Aga Khan University Hospital. Dr. Nasiruddin.
Thank you, Dr. Razak, for arranging this seminar and giving me opportunity to share my experience on sarcomas. Dr. Marco already described that the liposarcoma is the most common retroperitoneal sarcoma, and in my talk I shall discuss more about the liposarcoma and then leiomyosarcoma and malignant peripheral nerve sheath tumor. So liposarcoma is most common retroperitoneal sarcoma and also most common soft tissue sarcoma, overall comprising 25% of all soft tissue sarcomas. The term is like a sarcoma, but it is a heterogeneous group of tumors which show distinct morphologic and cytogenetic features. So there are four histologic types: atypical lipomatous tumor or well-differentiated liposarcoma, which is the most common one, comprising 40 to 45%. Dedifferentiated liposarcoma 10%, myxoid liposarcoma 30 to 35%, and pleomorphic liposarcoma 5% of cases. So, atypical lipomatous tumor or well-differentiated liposarcoma are the same tumor but with different names. It is called atypical lipomatous tumor when it involves extremities or neck, and the rationale is that the prognosis is very good in these locations because the tumor can be adequately resected and there is no recurrence in the extremity atypical lipomatous tumor. So that's why the sarcoma term is not used in the extremities. So well-differentiated liposarcoma when it involves retroperitoneum, mediastinum or paratesticular region. So there are three histologic variants: lipoma-like, sclerosing and inflammatory. So these lipoma-like well-differentiated liposarcomas can achieve very huge size, like this tumor which measures 60 centimeters in maximum dimension and weigh 10 kg. So addressing Dr. Asgar's questions, that in such a huge tumor, so pathologists cannot evaluate every aspect of the surface. So like in other tumors, you can identify the epithelial tumors or other mesenchymal tumors grossly from the normal tissue. But here it is all adipose tissue. So if we sample this whole surface, it may encompass 1,000 slides. So we grossly examine, and if is there any rupture or something, so we take section from there. Otherwise, like it is covered by a thin capsule, so we comment on that. So these tumors can encase adjacent structures, like in this case, it encased the kidney as well as bowel. So histologically, the lipoma-like variant of well-differentiated liposarcoma comprising of variable size adipocytes and these atypical cells. So even if a margin is negative from here, so since these atypical cells, they are few in number, so if they are not present in the margin which was submitted for examination, it doesn't mean that it is like the true one. Maybe in other areas, those typical cells may be present at the margin. So the other variant is sclerosing, which is more commonly seen in the retroperitoneum and paratestis. So this tumor has a firm consistency because of extensive sclerosis. And the third subvariant is inflammatory type. So this variant is the inflammation masks the atypical cells, which are few in number, and it is difficult to diagnose on two-cut biopsies because these cells may be if a needle is pierced in this area, it will show only inflammation and may result in erroneous diagnosis of an inflammatory process. So prognosis is good in the extremity, but it is worse in the retroperitoneum, and recurrence rate is approximately 30%. Risk of dedifferentiation is more than 20% in the retroperitoneal, and it is less than 2% in the extremity, and mortality rate is 80%, and it's due to repeated local recurrences and dedifferentiation. So the other variant is dedifferentiated liposarcoma. So this malignant sarcoma shows transition between well-differentiated liposarcoma and a non-lipogenic sarcoma, which can be low grade or high grade. Roughly 90% of dedifferentiated liposarcoma arise de novo, while 10% develops after recurrence of well-differentiated liposarcoma. So these are older patients with a male predominance, and majority are in the retroperitoneum followed by the extremities, and this can be very huge, and in 5 to 10% of cases there is heterologous leiomyosarcomatous, rhabdomyosarcomatous, osteo or chondrosarcomatous differentiation. So this specimen shows a huge fatty tumor encasing the kidney. This yellow part is the well-differentiated part, and the firmer whiter is the dedifferentiated part. So if a needle takes sample from this area, so it will give you diagnosis of well-differentiated. So it is necessary that these cases should be discussed before biopsy, and these both areas should be sampled so to give a correct diagnosis. So this is the differentiated liposarcoma. This part is the well-differentiated part which shows lipoblasts, and this is the dedifferentiated part. This dedifferentiated part can be of any shape. It can look like undifferentiated spindle cell sarcoma. It can look like pleomorphic sarcoma, epithelioid sarcoma, or a solitary fibrous tumor like. So in most cases, this dedifferentiated part is high grade, but occasionally it can be of intermediate grade or low grade. So there are accelerators for diagnosis of well differentiated and dedifferentiated liposarcoma. So these tumors show amplification of MDM2, CDK4 and CPM genes on chromosome 12. Immunohistochemistry is available against these genes, which are expressed in more than 90% of liposarcomas. But immunohistochemistry is not reliable because immunohistochemistry of MDM2 can be positive in other sarcomas, mainly malignant peripheral nerve sheath tumor, in which it is seen in more than 60% of cases. P16 is another marker which is expressed more than 80% of the cases, but this immunohistochemistry is also positive in smooth muscle tumors. So FISH should be performed in two-cut biopsies in which you don't have an answer. So this FISH for MDM2 is available in our lab. So dedifferentiated liposarcoma has a 15 to 20% of metastatic rate. So interestingly, the morphological grade, whether it is low grade, high grade, does not influence the prognosis. And this dedifferentiated liposarcoma is a better prognosis than other types of high grade pleomorphic sarcomas. So third liposarcoma type is pleomorphic liposarcoma. This is more common in the extremities and rarely in the retroperitoneum. Histologically, it shows very pleomorphic lipoblasts, but there are no well differentiated liposarcoma like areas like you see in the dedifferentiated liposarcoma. So prognosis of this liposarcoma type is worse than the dedifferentiated liposarcoma. The fourth type is myxoid or round cell. So in the past, round cell liposarcoma was considered a distinct entity different from the myxoid, but these two liposarcomas share the same cytogenetic abnormalities. So in fact, round cell liposarcoma is the higher grade of the myxoid liposarcoma. So this is most common in the extremities and most common sarcoma of children and adolescents. So it is very rare in the retroperitoneum, pelvis and mediastinum, and these cases may likely represent metastasis or may be mistaken for myxoid change in the well-differentiated liposarcoma. This is the characteristic histology of myxoid liposarcoma. These are the vessels which are called chicken wire vessels, a myxoid background, and univacuolated lipoblasts. So these two translocations are seen in myxoid liposarcoma. The most common is 1216, and which is seen in more than 90% of cases, and the other is 1222. So local recurrence and distant metastasis are 30 and 40% respectively, and the metastatic grade is directly related to the histologic grade, and the pathologist should report the round cell areas in the myxoid liposarcoma because it adversely affects the prognosis, and more than 5% round cell areas affects poor prognosis. Overall mortality rate is 25 to 40%, and it is interesting that this sarcoma gives metastasis to other soft tissue areas like contralateral extremity, retroperitoneum, bone and lungs. So we do not grade well-differentiated liposarcoma because they are grade 1 by definition, and dedifferentiated and pleomorphic liposarcoma, they are grade 3 by definition. So pathologists should report grading of myxoid and round cell liposarcomas, which can be grade 2 or 3 based on round cell areas and necrosis quantity. So this is the 5-year Aachen University Hospital laboratory data from mid 2013 to 2018. So during this 5-year duration, 282 liposarcomas were reported in total, and there were only 52 cases of retroperitoneal liposarcomas. So a male predominance was seen, which is like to other studies, and mean age was 51 years and mean tumor size was 22 centimeter. So like the breast studies, dedifferentiated liposarcoma was the most common, followed by well-differentiated liposarcoma. Pleomorphic liposarcoma, in 2 cases on core biopsy, the liposarcoma could not be subtyped. And in 1 case, a metastatic myxoid liposarcoma was from the extremity was reported. The second sarcoma of retroperitoneum is leiomyosarcoma. They are mostly seen in adult females, and in fact about 2/3 of retroperitoneal leiomyosarcomas and more than 3/4 of vena cava leiomyosarcomas occur in women. So the reason is unclear. It may be related to estrogen stimulation. Histologically, these can be of low grade or higher grade, and they express smooth muscle actin and desmin. Last, we see a few cases in the retroperitoneum malignant peripheral nerve sheath tumor. So these tumors occur in 3 distinct settings sporadically in patients with neurofibromatosis and following radiation therapy. So in malignant peripheral nerve sheath tumor, heterologous differentiation is seen in 20% of cases, and this heterologous differentiation can be of rhabdomyosarcoma, which is called malignant triton tumor, chondrosarcoma, and osteosarcoma. Histology of malignant peripheral nerve sheath tumor, palisading necrosis, and this is malignant peripheral nerve sheath tumor with rhabdomyosarcomatous differentiation. So it is an aggressive tumor. So in contrast to a dedifferentiated liposarcoma, in which heterologous differentiation does not influence prognosis, in MPNST, the heterologous elements result in aggressive clinical behavior. So what are the local challenges and problems in sarcoma diagnosis? The first one is inadequate clinical history. So we receive a lot of cases, two-cut biopsy, abdomen or retroperitoneum, had no idea from which organ it originates. Like in one case, it was a recurrent liposarcoma. So on recurrence, it showed a heterologous differentiation, and we reported that as leiomyosarcoma. Then we got history that this patient had been operated for liposarcoma. So this is very important. History of any neoadjuvant therapy is not provided, which results in tumor morphology alteration and loss of immunohistochemical marker. The other is inadequate radiological features. So we received a two-cut biopsy on which we struggled, and finally which was coded as mass retroperitoneum. So we reported diagnosed that case after extensive panel of immunohistochemical stents as chordoma. And then we asked for a radiology. So there was actually a sacral chordoma extension into the retroperitoneum. Similarly, a case of giant cell tumor was sent as mass retroperitoneum. So that is very important. So the other is lack of communication between physician and pathologist. So certain things, operative findings and issues can be resolved on simple communication. The other is resistance to go for molecular studies. So now in every conference you talk about moleculars. We have developed molecular for synovial sarcoma, Ewing sarcoma and liposarcoma. But when I ask for our colleagues that you should send request for this to confirm diagnosis. So okay, this is sarcoma, no matter. So why we waste money? So but this is not how the pathologist will learn that whether he made a diagnosis right or wrong. So how we can develop our expertise if we are not sure the diagnosis was. So the other is lack of data for soft tissue sarcoma epidemiology and outcome. So the AQH laboratory has a huge data, but there is no support, collaborative support, because those referral cases we don't have contact number outcome. So it is just the number, not so there is need for collaborative studies, so to get expertise and gain our local experience. Otherwise we quote just the Western studies that this is the recurrence rate for that sarcoma. Thank you.
Thank you very much, Dr. Nasruddin. Any questions from the audience?
What should be the adequate size of a biopsy specimen?
So
Actually, from 4 into biopsy, we are doing what should be at least adequate size of it?
it should give the lesional tissue. For example, if you remove 3 cores, 4 cores, if it does not represent the lesional core, then those are of not use. So there is no criteria which the sample accuracy, in other renal, others, that certain number of glomeruli, in the liver, certain number of portal tracts should be, but there is no the size. It should represent the lesion.
But at least a core biopsy. Sorry, Dr. Mark. Sure.
We usually try to give at least 4 or 5 samples of the biopsy, not because less samples are not informative, but because we want the pathologist to make the diagnosis, to make the immunohistochemistry, and then we ask the pathologist to keep the material. So we use the material also for banking, because it will be very, very useful. Maybe you give some neoadjuvant treatment, and I really agree with your point that you need to collect data, and data should be correlated with outcome, but it is very, very crucial also to have material. So we are collecting tissue material also prospectively. We don't know what will be useful for, but maybe in 10 years we have to go back to our material and analyze and understand in a study.
Good, thank you.
Thank you very much, Dr. Nasir. Sorry.
Dr. Nasir, thank you very much for this talk. We are very important that in the book, there almost all types of sarcoma, there is some mutation, there is some translocation, they have written that book for the ophthalmological evaluation book for these testing things. Like in the case of Ewing sarcoma and synovial sarcoma, we have very good testing and you are doing that very well. Do you think that we should go for all these types of cytogenetic analysis, even if they have confirmed on the morphology, that this is something like liposarcoma, this is something like retroperitoneal? Do you think that we should go for these cytogenetic analysis in all cases or not?
Yes, we should go, because at least in that where we will have our local data. For example, the synovial sarcoma translocation is said to be positive in 90% of cases. So immunohistochemically, the markers, after some time, we experience that these immunohistochemical markers, which are said to be specific for synovial sarcoma, turn out to be positive in many other tumors. So that diagnosis based on the immunohistochemical morphology may be not correct.
The thing is, when the treatment plan will change, that is specifically for the Ewing sarcoma,
Yes.
not for all other. If you are saying on the morphology that the retroperitoneal sarcoma, this is rhabdomyosarcoma on the basis of morphology, right?
So even in rhabdomyosarcoma, sometimes it is difficult to classify rhabdomyosarcoma on immunohistochemistry and morphology. Between embryonal rhabdomyosarcoma and alveolar rhabdomyosarcoma, which can sometimes mimic, and the immunohistochemistry is same. So there is molecular alveolar rhabdomyosarcoma behave aggressively than the embryonal, and there is translocation for alveolar rhabdomyosarcoma.
Embryonal by definition is grade 3.
No, but the alveolar, it behaves more aggressively than the embryonal one. So there is translocation for alveolar rhabdomyosarcoma, FOX9. So similarly, Ewing sarcoma, for example, if we say this Ewing sarcoma, CD99 immunohistochemistry, which is said to be positive in Ewing sarcoma, also positive in synovial sarcoma and many other tumors. So that is not reliable. The other thing is that, like it is said that Ewing sarcoma, this translocation is 90 to 95% of cases. Now the remaining cases, like which show immunohistochemical positive for CD99 and which look like Ewing sarcoma, now they are classifiable, and those are different sarcoma groups which are called B-course sarcomas and sick ducts sarcomas. So these molecular abnormalities have been identified in those 1122 translocation negative Ewing sarcoma cases. And these cases of Ewing sarcoma behave aggressively than the conventional. So if we do not perform this molecular translocation, how we can diagnose the other one? If molecule is negative, then we'll think about the other one. So by immunohistochemistry, both will show staining for CD99.
Can I make a comment? I agree with everything you say. I had the privilege of being the man who did the sarcoma work at Anakin Institute at the University of Florida, but I was there for many years. This is a rare group of tumors, and I think that everything has to go to a pathologist in referral areas, because it's not a large volume of people. What you see in this country is they all say it's a spindle cell tumor or a round cell tumor. I mean, this is how they split it. But actually, I think what you say is absolutely correct. And the problem is that the patients get the initial biopsy, and then for each testing, they have to pay from their pocket. And I think that's the core issue generally present. But I think that your specialty and with the coming of Dr. Raza's commitment, I think it should make a difference in the years to come. I really do.
One more question. I'm sorry. When you're saying we have to grade the whole of the sample in terms of necrosis also,
Yes.
0, 1, and 2.
Yes.
If you have given some neoadjuvant therapy, or even if you don't have, you haven't given any neoadjuvant therapy, and but the surgeon put it resected completely in toto, do you think that in the incompletely resected section you can properly report the necrosis if that part is showing necrosis grade 2 that has not been resected, more than 50% has not been resected? How can you say that the necrosis will be grade 2 or grade 1 or grade 0?
So this is the problem in clinical information. We even, like sometimes samples sent as excision biopsy, well, those are the incision biopsy. Sometimes they code it incision biopsy. Those are, so if you provide that information like to us, then we will report that this is may not be, we will definitely grade it, but we'll write a note that because our colleagues pushed us a grade on even core biopsy, try to grade. So like have different their way of doing things. So we'll write in a note that this grading was done attempt on this partially resected specimen and may not be the true picture.
I think in addition, in patients who receive preoperative chemotherapy, radiology plays an important role in kind of combining that grade. What would you say, like presence of necrosis on imaging?
Yeah, the grading in terms of necrosis can be evaluated only before preparative treatment, so afterwards is not reliable anymore. So this is the classification. What we use is the criteria that if you have a biopsy with grade 2 and maybe the necrosis is 0-1, then if you have any evidence of radiological necrosis, then you can consider to upgrade. So this is a decision of the NDT. You have a grade 2 on the biopsy. You have an MRI that is showing that the tumor is very, very necrotic. This actually does not happen really with the retroperitoneal tumors, but mostly with the extremity. Then you are allowed to treat the patient as a grade 3. That it makes the difference to give a neoadjuvant treatment or not.
But usually CT scan doesn't tell you about the level of necrosis. You have to go for either PET or something like MR before surgery.
Yeah.
You're saying that
well, I told you that this happens mostly for extremity tumors. It's very, very rare that the differentiated liposarcoma is grade 3 because of necrosis. It could happen for leiomyosarcoma, but you have some evidence on the CT scan as well that the leiomyosarcoma is dishomogeneous. You can see some hypodense zone in the tumor, so it can happen, but usually it happens for extended tumor. For retroperitoneal tumors, the difference is for the differentiated liposarcoma. I agree with the pathologist that you have to perform all the immunohistochemical panels and whatever molecular studies you can do. Because, for example, for the differentiated liposarcoma, we not only see the grade, if the grade of the differentiated part is G2 or G3, as I shown you on the curve, but for example, if the differentiated part has heterologous, the differentiation in terms of myogenic tumor or even rhabdomyoblastic tumor, then the outcome is worse. In our series, no one single patient with rhabdomyoblastic dedifferentiation of the dedifferentiated part of the liposarcoma will be alive at 18 months after surgery. No one, single one. So if you have this information on the biopsy, this is absolutely patient candidate to systemic treatment, whatever is the extension of the disease, because the risk of this patient is to die of metastatic disease. It's not the urgency to go to the theater, maybe to receive a HER2 resection. So this patient is candidate to a systemic treatment. So the diagnosis is the key.
I think you said that a de-differentiated will differentiate into better differentiated. Does that ever happen?
De-differentiated?
Can differentiate into a better?
Yes, on recurrence.
It can?
It can, yes. It can recur as a well differentiated.
Yes.
And
how often does that happen?
there's like lack of
I've never seen that in my limited experience.
It's more common that a well-differentiated sarcoma will recur like a de-differentiated one. This is one other reason not to give downstaged treatment at the beginning, because in case of recurrence you will have a high-grade tumor then. But it can happen that a de-differentiated tumor may recur with a well-differentiated mass, for example, on the critical side near the duodenum, or even intraperitoneally it happens. So in that case, you can even decide. If you see that the recurrence is completely well-differentiated on the radiology, you can expect then the recurrence is indolent. So sometimes in this situation, we just decide to wait and see, because we know that patient will not be cured anyway. The patient will be asymptomatic because there is a little well-differentiated nodule on the duodenum. So maybe it will be stable for 1 year, 2 years before starting growing. So any chemotherapy will of no use because he is asymptomatic, is not growing, is well differentiated, so it's less active. So we will wait for tumor progression in case of well-differentiated recurrence of the differentiated tumor. At time of tumor growing, we will decide whether, according to the progressive pattern, we will decide whether the patient is candidate to second surgery or chemotherapy or maybe radiation. But it's not so uncommon. I would say that 30 to 40% of the recurrence of the differentiated liposarcoma will be with well-differentiated nodules.
No, in a well-differentiated, in a liposarcoma with mixed areas, dedifferentiation work, how do you classify a prognosis? How do you state the prognosis? Supposing there's a 5 to 10% dedifferentiated,
No.
and 90% is,
No,
is there a way
in our figures, they are classified according to the worst part of the specimen. So if there is a single nodule component, solid component that is grade free, then the tumor is classified as grade free. So the worst part.
So it doesn't matter
Whatever the extension.
whatever the extent.
Yeah. At least this is to simplify in the figures. So we do not have a nomogram yet that is classifying the extension of the G3 component, but if you find a G3 component, then this is a high-grade tumor.
Then again, when sometimes it's a retroperitoneal well-differentiated liposarcoma with an area of dedifferentiation, and sometimes the radiology reports only picks up that area of dedifferentiation as the mass and ignores the rest of the well-differentiated component as normal retroperitoneal fat, and then if only that part is targeted and taken out, that recurrence will be a well-differentiated recurrence, or residual if you want to call it that. So that may be one of the reasons.
The other is that because the dedifferentiated liposarcomas, they originate from the well-differentiated one. So maybe this is the reason that they recur as like the well-differentiated. So the well-differentiated part may recur as of the dedifferentiated liposarcoma may recur as a well-differentiated one.
If there are no questions, there's this particular aspect on diagnosing and how to plan the biopsy for retroperitoneal sarcomas, especially for liposarcomas, because they will have some, especially if there are areas of dedifferentiation. Should we target each area separately, and or we just biopsy the mass?
You know, we discussed with the radiologist which should be the more aggressive part, according to the solid part, the presence of necrosis and the extension of disease and the radiological pattern in general. So we asked to target the worst part, because we want to know the worst part of the tumor. Sometimes it's not feasible, because if this nodule is not reachable with the needle from percutaneously, sometimes it's not feasible. Okay. Sometimes you have maybe very necrotic lesion or difficult to establish. So sometimes the radiologist asks us to stage the patient with a PET scan, for example, and we decide the more aggressive part according to the PET scan. But this is a minority of cases. If we are not technically able to reach the worst radiological part of the tumor, then we together in the MDT can consider the diagnosis can be downstaged respect to the actual extension of disease.
Does radiation work for myxoid in retroperitoneal locations like it works in extremities?
Yeah, absolutely yes. But if you have a myxoid liposarcoma intra-abdominally, the chance that this is a metastatic disease is more than 90%. So you can consider radiation therapy, absolutely, but you have also a number of drugs that are very active in myxoid liposarcoma, but this is another setting. This would be metastatic disease. So, but the answer is yes, it works.
So may I ask, in the finality, you want to know whether the tumor is dedifferentiated or not, because you want to make a decision on preoperative treatment. Is that your major concern in the beginning?
This is one of the major concerns. The second major concern is that you can modify your surgical strategy according to the aggressiveness of tumor. So if I'm sure that the tumor is low grade, I will be the more aggressive I can. It's exactly the opposite that you would have think, because this is a curable patient. Okay. If it is a very aggressive disease on the biopsy, then I would rule out to manage and to have a compromise, for example, with the general condition of the patient, the age of the patient, the extension of the... I would not offer a pancreatic duodenectomy to a patient with a locally advanced G3 dedifferentiated tumor. But for example, I would consider for a well-differentiated liposarcoma. So it's not only for neoadjuvant treatment, so it's for surgical strategy, and in case of high-grade tumors, then to be able to discuss in advance the strategy for adjuvant effects.
Dr. Fahad, sorry. Yeah, I wanted to make a comment on a couple of things. One was obviously the biopsy the lesion. I completely agree with you. It's always a diagnostic dilemma. When reporting such scans, what really happens is, can I come there? Right. Obviously, the component of the tumor, in totality, when you need to report these scans, what usually happens when we encounter is, like Dr. Raza said, the fat component of the lesion is usually underreported.
Yeah, absolutely.
Exactly. So the appearance of that is almost parallel to the normal retroperitoneal fat.
Absolutely.
And again, the second point which I need to make is the biopsy that you had correctly said. Now what we need to biopsy, like I agree with Dr. Marco, is that we need to biopsy the necrotic component or the enhancing sinister looking part of the tumor. See, the needle, if you can access it, fair enough. If you can't, usually what we do is at times, and we should not, is we biopsy the fat component of the tumor. And this is what the pathologist receives. And that again becomes an error in reporting. And that becomes a roadmap to the surgeon as what to expect and treat by chemo or radiosurgery. So the aim of the biopsy is that you need to go take your needle in to the sinister enhancing necrotic component of the tumor. Third and foremost, lastly, the necrosis, I think necrosis is quite clearly seen on CT as compared to PET or NMR. The non-enhancing or the poorly enhancing components of the tumor is what we depict or interpret as necrosis. And that is the most sinister part. So the length of the needle of a biopsy is about 9 inches. So you can take the entire core in. The core that we take, the size of that is about 1.5 to 2 centimeters. So I think it's always advisable to take 2 or 3 cores, say from the fat component, the enhancing and the necrotic. Because the tumor usually what we encounter when on imaging is almost about 10 centimeters in size. Those are big chunky lesions. So I don't think it's really difficult to biopsy them.
People are saying that if you want to confirm the part of the necrotic part of this mass, you have to check for the PET scan first. The PET is more reliable than to label having a necrotic element of all.
I think Dr. Asgar, I would beg to differ on that. I think PET, yes, it can pick up areas which would be FDG avid, which may not be seen on CT. That's what the role of PET CT comes in. But about necrosis, I think again that's what literature backs up. I would back this up. The statement about literature is that CT again is more accurate, more sensitive and specific to pick up necrosis rather than CT PET.
Yeah. Sorry, Dr. Raza, I would make it very simple. If you discuss all these things before the biopsy, anybody know what is doing, which is the information needed, and which is the meaning of the reporting after biopsy. Because, I mean, if you decided that we cannot reach that part of the tumor, we are obliged to stay in the well-differentiated part. I know that this is only a part of the tumor, then the surgical oncologist know what is the meaning of the diagnosis that is on the biopsy. He can put all the information together. So this is, I think this is the key point.
Another question is biopsy. Do you think that if there is a mass retroperitoneal which you are seeing that I can take it off very comfortably, we should go for the biopsy of that ear first before going for the surgery of that ear in the retroperitoneal?
Should we always biopsy retroperitoneal masses, especially in cases where we can easily excise them?
Absolutely, yes. Because you are offering the patient a colectomy, a nephrectomy, maybe a duodenopancreatectomy, and you have no diagnosis. Would you operate a patient for rectal cancer without diagnosis?
No, not for that, because most of the time for the RP sarcoma, your biopsy is somewhat difficult as compared to the rectal sarcoma. If there is an area which is quite well localized over there in the RP region, and you can say that I can take it out very easily, and looks to be well localized here, do you think that we should go for the biopsy
Yes.
to confirm it?
Yes.
I mean, you already
We'll
said.
change our treatment plan. until unless we are planning for new.
The only reason not to have a biopsy would be that it is not technically feasible. Otherwise, there is no reason not to have a biopsy.
But I mean, it can also say like this, that if we are saying that it's a well-localized DN and you're not planning for a new adjuvant therapy specifically for that, and if it can be resectable, take it out in total.
I would ask for a biopsy anyway, because I may be wrong, it happens. Okay, I show you some differentials. Maybe it's a myelolipoma, maybe it's an angiomyolipoma. It is easily resectable. It's identical on the CT scan to a well-differentiated liposarcoma, but it's a benign tumor. In case it is an angiomyolipoma, I would try my best to preserve the kidney, because it is a benign tumor. If it is a well-differentiated liposarcoma, no way to distinguish on the CT scan. That's not true, there are some hints, but I mean, they are not finally reliable. You need a pathology report that this is a benign tumor and it is not a well-differentiated liposarcoma. And this happens also in experienced centers that you cannot distinguish between the two. So the only reason not to have a biopsy preoperatively is that biopsy is not technically feasible. I don't find any other case.
Also, when we look at the approach, it is look at the risk of local recurrence versus risk of systemic spread, and there and we decide our strategy. For example, for leiomyosarcomas, we will not kind of advocate a very wide compartmental resection, am I right? Because leiomyosarcoma you can easily differentiate from retroperitoneal fat, but you can't differentiate well-differentiated liposarcoma from retroperitoneal fat, so you have to take all of the fat out to make sure that you have perceived it. But for a leo, which has higher risk of systemic spread than local recurrence, we need to know this is leo so that we don't be very aggressive with the local treatment or local resection. Would you agree?
Yeah, absolutely. And I show you some CT scan where leiomyosarcoma is identical on the CT scan to a solitary fetus tumor. The risk of local recurrence is nearly zero. Okay, so
we have little issues and big issues. I think largely, basically, retroperitoneal sarcomas are surgical diseases, right?
yeah,
And most of these MDCs, the surgeons lead.
yeah.
The medical oncologists say, yes, we will do what you say. I think that is what we essentially have to do, because I think we come number second or third to the decision as to what's to be done by the surgeons.
Yeah, I agree with you. I would say in our entities usually surgeon asks for chemotherapy and medical oncologists ask for surgery. So it's very, very interesting MDTs. But for retroperitoneal tumor, it's true. I mean, the leading is in the surgeon oncologist, but there are many, many situations where you cannot decide on your own. For example, okay, to have the correct diagnosis, and to decide the strategy, because for radiation therapy and for in part also for chemotherapy, after surgery could be too late. I mean, we cannot offer radiation therapy anymore, and you cannot miss a chance to verify also the activity of medical therapy that if you give in advance, you can verify in vivo the activity of that, because there is the big issue of the efficacy of chemotherapy in soft tissue sarcoma, but if you give before, at least you can verify the activity.
So actually, the reason I bring this up is because we have to be very careful about what we use. I think our traditional medicines, the anthracyclines, the hyphosphamides, these are really the most effective. For example, only last month, the FDA and the European Medicines Group removed the Truco, which is the BTF alpha, as an ineffective.
Olaratumab.
Yeah. So for 2 years on a phase 2 study, everybody's using it, and now they're saying. But I think there are some maybe new drugs coming, including targeting the MDM2 and others. So maybe like many other tumors, we will be able to shrink down if we are lucky in this future.
Yeah, you're right. But for example, leiomyosarcoma, you have a number of options. So you have the gemcitabine, you have the carbazine, and you have There is also trabectedin. Okay, and so there is a number of, but I think that the point is not the kind of regimen. The point is the strategy. So then, once you have decided the strategy, the medical oncologist can say, okay, I have no active drugs in this histotype, so sorry for you, it would have been useful, but we have no drugs, for example, but otherwise you give a try. And if you want to give a try, you have to verify the activity of the drug. So this can be done in the neoadjuvant setting, cannot be done in the post-operative setting.
Are there any data, do you have any experience with the preoperative chemoradiation?
Yes. So we ran a trial, the activity. We chose this couple of ifosfamide and radiation therapy because we think that it was a radiosensitizer. Okay, but presently we don't have yet the evidence of the efficacy of preoperative radiation therapy, so this is an issue. And then there is the problem of that the ifosfamide is not considered anymore a good drug for leiomyosarcoma. And adriamycin and dacarbazine can be feasible with radiation therapy, depending on the field, but usually it's feasible. And for extremity sarcoma, I can tell you that our standard approach is anthracycline and ifosfamide, concomitant radiation therapy in the neoadjuvant setting. These are the published data of the neoadjuvant study of the Italian sarcoma group, that is the one who showed the major advantage in terms. And it is really feasible. I mean, you have to keep the patient close to you, because if we have a patient who receives chemo radiation in the neoadjuvant setting, we prefer that the patient is in our institution and not maybe in another city or another region, because I mean, it's a neoadjuvant treatment. You have to plan to operate the patient in case of any kind of surprise of complication or side effect. You have to repeat the NDT and decide what to do. But in terms of feasibility, it is absolutely feasible and safe.
In that data which was published for the chemoradiation with the MAID regime,
With the
MAID regime, they gave the MAID,
MAID.
ICOS,
Yeah.
and the Yeah, and there's only 48 patient data they have presented on the right now. 48 patient data, they are showing some response to the chemoradiation. Do you think that this should be the standard practice of for the patient with the retroperitoneal sarcoma also? Because there must be some toxicity.
No, so presently chemotherapy and radiation therapy are not a standard treatment for retroperitoneal sarcoma. Okay. On the opposite, radiation therapy is a standard treatment for high-risk extremity and trunks of tissue sarcoma. Chemotherapy is not the standard, neither for retroperitoneal or extremity. It is offered on an individualized basis to patients with extremity tumors, and this is stated in the last ESMO guidelines. According to the recent results with epirubicin and ifosfamide in the high-grade tumor, but there is no standard guidelines for chemotherapy for retroperitoneal tumors. The study you mentioned is no study. This kind of regimen is poorly used presently worldwide.
Anybody uses that dacarbazine, there's no guidelines, original paper.
Yeah, we are using dacarbazine coupled with adriamycin, limited to leiomyosarcoma. And by the way, last study we ran was a standard study who randomized, according to histology, epirubicin and ifosfamide to a target histology-tailored treatment, and adriamycin dacarbazine was tested in the leiomyosarcoma subgroup. Results are not still published. This is only an interim analysis, and probably we expect that adriamycin and dacarbazine will not be inferior to adriamycin and ifosfamide. Not inferior. So you
information on the use of gemcitabine. That's a very good.
Yeah, it works. It's active in leiomyosarcoma in the metastatic setting, and gemcitabine can be used either as a single agent or together with taxane.
Sure. But
Gentax is a very fashion regimen in the United States for leiomyosarcoma, and it's active, absolutely active.
For preoperative radiation?
No.
Because the MD Anderson had a paper on the extremity sarcoma years ago on the use of gemcitabine as a radiosensitizer. But one of the problems here is that the radiotherapists who take names are, they just don't want to give preoperative radiation to the extremities. Am I right?
Yeah. Only radiation.
Am I right? And so we've been harping for years that you need to do that. And for the extremities.
So I can tell you that epilogus nifosmide is feasible with the preoperative radiation therapy. We ran a study of feasibility of trabectedin with radiation therapy. I'm not sure that this has been published, but it will be published, and it's feasible. Adriamycin dacarbazine is feasible. Gentax, I don't have data.
Thank you very much. This is very interesting, and I don't think we can have any problems running late, but it's only I who's going to get into problems. Anyway, one of the points that Dr. Fiore brought up is very important, that sometimes in the soft tissue sarcoma, MDT, you can bring cases without all the aspects of information. So before biopsy, looking at the radiology to decide what would be the most feasible area of biopsy, especially for retroperitoneum. That's okay. We should not be looked down upon just bringing incomplete cases to MDT, because that makes a difference to the patient's management. And I think that's what we should take home. Thank you very much, Dr. Nasir, for your intriguing talk on pathology. The last talk, which will be then followed by discussion of cases, is by Dr. Bilal Qureshi, and because of the multidisciplinary nature, many of the points that he is going to talk about have already been encroached upon, but it will be good. Dr. Bilal is a radiation oncologist at our university, and he's going to talk about the role of radiation oncology.
Bismillahirrahmanirrahim. Thank you, Dr. Marco, for being here in Pakistan and emphasizing the need of an MDT and a focus group for the management of retroperitoneal sarcoma, because the standards we have already been discussed. It's a rare disease, not very common, and as for other modalities in terms of the role of radiation therapy, we definitely lack randomized data in this aspect. So sarcomas are generally rare tumors. I will not go into the details of histopathology, but just to remind that most of these tumors which we are dealing with are liposarcomas with different grades, or leiomyosarcoma. Then definitely biopsy has a role and should be done with expert hands, discussion with the radiation oncologist and surgeon upfront. So for almost all of the retroperitoneal sarcoma, either because of large size and because of high grade, a lot of them require upfront radiation therapy or some sort of neoadjuvant treatment, except for the tumors that are high grade and where we have the liberty of going into offering radiation therapy. Adjuvant therapy has not been established as a proven treatment or in the guidelines according to the NCCN guideline in the adjuvant setting. So Dr. Marco has already emphasized upon the role of the resectability and detecting it early on during the evaluation or diagnosis, already been clarified that inferior vena cava may not be an absolute indication, a contraindication for upfront surgery, but peritoneal implants and distant metastasis does play a role. I would like to emphasize upon the involvement of vena cava or other structure where the tumor is splashed upon from, the neoadjuvant radiation does play a role in creating a pseudocapsule around the tumor, but at the same time, if it is used with intraoperative radiation therapy, IURT or brachytherapy with HDR high dose rate brachy may result in the same toxicity we would have been afraid of with surgery. So the study from French group evaluated the pattern of care at diagnosis, prognostic factors, and the focus on the main histological type. Have proven that surgery in a specialized center, a multidisciplinary approach, avoidance of piecemeal resection, upfront meticulous histological examination, and categorizing into histopathology subtype and involvement of a whole team in a specialized center does play a role in improving the outcome of retroperitoneal sarcomas. So I would like to first of all clarify and put aside the role of adjuvant treatment, specific adjuvant radiation therapy in retroperitoneal sarcoma. We have evidence from two major groups, the French group and the National Cancer Database from the US. These were not randomized data, but have proven that the role of radiation therapy is with upfront surgery is better in terms of local control, but does not necessarily translate into overall survival. It's as there is no randomized data on it. The retrospective analysis from the National Cancer Database from the US proved the same results. So what are the actual challenges that I would like to highlight with post-operative RT planning? So the information that we have from the tumor biology, from extremity sarcoma, that higher dose of radiation therapy is required, up to 66 gray, 50 gray has to be offered to a large volume, and in cases of R1 resection, 16 to 18 gray boost to the area of microscopically positive margin, and when we have gross residual disease, we have to go up to 20 to 26 gray. So that becomes a problem in terms of radiation treatment planning and delivery, because most of the structures present in the vicinity are radiosensitive and have a tolerance limit much lower than the prescribed dose. Some information that we can get help from is from the surgical clips. If the surgeon can place the clips in the retroperitoneal structure, like if it is cracked off from psoas or the posterior abdominal wall, it can be easier to boost that particular area, but at the same time, in the resection cavity, what we get post-op is the presence of the normal structure. You can see this case operated for well-differentiated liposarcoma, but having some component of dedifferentiation in it, and the post-operative planning scan shows the presence of the descending colon and small wall in the resection cavity, which could have been irradiated with much better sparing of the normal structure in the preoperative setting. So another case when nephrectomy has to be done and whole of the tumor bed is occupied by gut, liver, and the vessels. So similarly, for pre-operative radiation treatment planning, it's almost the standard of care, but we still lack randomized controlled trial with proper accrual. Some of the trials were started but could not be completed. The advantages that we have from pre-operative treatment is that the gross tumor volume can be very precisely drawn, and because of the tumor effect, the pushing nature of the tumor, the normal structures are pushed away and only a minimum margin of those normal structures like kidney and the bladder comes in the high dose region. So it's safer to deliver the dose. The dose is also lower, up to 50 gray. The higher RT doses can be delivered to the actual tumor field since bowel adhesions to tumor are less likely compared with the post-operative setting. There is decreased risk of intraperitoneal tumor spillage with the dissemination operatively, because we might be able to produce a pseudocapsule around the tumor, and biologically the dose results in greater cell killing for the dose delivered because of greater oxygenation and good blood supply to the tumor. And in some cases we may be able to convert potentially unresectable tumor into resectable one for cure. So this was a comparison of retroperitoneal sarcomas with the comparison at two different centers. Most of the baseline characteristics were well matched. However, some of these patients in the radiation therapy treatment group had tumors extending or arising in the pelvis. But in this study, the radiation therapy used along with surgery in the preoperative setting had local control and local recurrence-free survival better than surgery alone. However, it did not translate into significantly better disease-specific survival. So, with the development of radiation treatment technique and the availability of proton beam radiotherapy, it has been used now in the neoadjuvant setting along with IMRT, either of them, but most of the centers like in North America use intraoperative radiation therapy with electron as an adjunct to this treatment, and has been able to give better margin posteriorly for microscopic residual disease. So this strategy may minimize radiation-induced morbidity and reduce local tolerance, local recurrence, especially in patients with the primary diseases. So initial results of a trial of preoperative external beam radiation therapy and post-operative brachytherapy for retroperitoneal sarcoma. So this actually differs from intraoperative radiation therapy with electron applicator, which uses the application of high-dose grade brachytherapy with implants that are placed during the course of radiation therapy, implants, the catheters which are placed during the course of surgery, and after the delivery of brachytherapy with high dose rate, with the enrollment of radiation therapy, the surgeon goes on with the completion of the treatment. So the 2-year overall survival and disease-free survival for dissected retroperitoneal sarcoma was 88% and 80% respectively, and significant better disease-free survival was achieved in patients with primary retroperitoneal sarcomas and those with low-grade tumors. So results from two prospective trials which flow due to Tour, one from the Princess Margaret Hospital and the other one from MD Anderson Cancer Center, both used preoperative radiation therapy. In the 45 gray was the dose used at PMH Toronto, and 18 to 50.4 gray was used at MD Anderson. However, the boost radiation used intraoperatively was different in both the study groups, and they were able to report a 5-year local recurrence-free survival of 60%, a disease-free survival of 46%, and overall survival of 61%, but this was not very well compared with the surgery alone data. So what they reported was that patients with intermediate or high-grade retroperitoneal sarcoma treated with preoperative radiotherapy plus complete resection had a median survival of more than 16 months. But before using this data, and applying it to our patient, we have to be careful for the lack of availability of intraoperative or Vedi therapy in Pakistan, and whether we would be able to timely deliver even neoadjuvant dose of 50 gray to the retroperitoneal sarcoma before surgery without delay because of the lack of availability of resources. The same database from North America also looked at retrospectively between patients for retroperitoneal sarcoma who were treated with upfront radiation therapy versus no radiation therapy, and the overall survival was reported to be 110 months in patients who were offered preoperative radiation therapy versus those who were not offered radiation, and the hazard ratio for death was 0.70, which was significant. So intensity modulated radiation therapy has evolved over the years, available at some centers in the country, mostly in the private tertiary care hospital, has been proven to be beneficial, and what people have been trying is that rather than irradiating whole of the tumor volume before surgery, what they have achieved through multidisciplinary team is to mark the area which is or may be adherent to the posterior abdominal wall, and this requires close collaboration with the surgeon upfront, not only at the diagnosis but at the time of marking the tumor as well, at the time of radiation treatment planning. But even in these efforts, they have reported some sort of recurrence post-operatively out of the boost volume, which was obviously done with the help of the prediction from a surgical oncologist who was going to operate in these tumors. So preoperative radiation therapy with selective dose escalation to the margin at risk for retroperitoneal sarcoma has been studied, and this was also a prospective but single arm study, and what they did was not only to identify the whole of the tumor but to simultaneously boost the area which the surgeon would think that could have been a potential site for microscopically positive margins. So this again emphasizes the need of close collaboration between the surgeon and radiation oncologist at the time of radiation treatment planning as well. So preoperative radiation therapy with selective dose escalation to the margin at risk was found to be tolerable, and it allowed higher dose radiation to the volume judged to be at greater risk for local recurrence. So we heard about the STRAS trial, which is a collaborative study. We hope to see the results of it soon, and whether what's the effective particle for the delivery of neoadjuvant radiation therapy. Is there proton or photon for retroperitoneal sarcoma? We yet to see the results of it being from the trial being done by Mass General Hospital in US, and there is a considerable amount of evidence being used for neoadjuvant radiation therapy based upon the RT controlling guideline. Unlike the adjuvant radiation therapy for retroperitoneal sarcoma, where we do not have any contouring atlases and effective delivery of radiation therapy complete dose of more than 66 gray is not possible. So we all need to understand that how we always talk about delivering preoperative radiation therapy, defining good volumes around it, but at the same time it requires a lot of expertise on part of a radiation oncologist. This may be taken as a recipe book for preoperative planning or retroperitoneal sarcoma, but we need to be cognizant about the fact that how these guidelines or contouring atlases are evolved. So this particular one was evolved through two tumors of retroperitoneal sarcoma, which was given to 12 different radiation oncologists, and 12 different radiation oncologists do the preoperative volume on this, and the guideline that we have over there is through the 95% nominal curves that they were able to achieve through it. So that emphasizes the importance of peer review in radiation treatment planning and identifying the high risk gross tumor volume boost, and of course, very important to involve the surgeon who is going to operate upon these tumors. You can see that the concept of giving a boost or a higher dose to the area posteriorly and towards the vessel where you may be suspecting a positive margin. So we have results from the transatlantic retroperitoneal sarcoma working group for leiomyosarcoma. The one to the leftmost of yourself is the well differentiated one. The next one for grade 1 and grade 2, and then for the grade 2 and grade 3 leiomyosarcomas, showing that RT offered preoperatively does result in better local control when they were studied alone, but does not really translate into overall survival according to this data. So what is the real local challenge? So now with the term local challenge, I do not mean an academic local challenge, but the geographic local challenge that we see in this country, and are we ready to adapt the pre-operative radiation therapy for our group of patients as a team. So the availability of machines in lower and lower middle income countries is still not adequate. So this is with reference from the data published by IAEA in 2017 and showing that the availability of linear accelerator has been improving, but still not up to the level that is available in the developed countries and good centers. So we need to look at that what we have available in our country, what our patients have got access to. Obviously, we cannot recommend suboptimal treatment and should not be deviating away from the standard, but have to adapt the best possible resources in a good manner. So most of the centers in our country, the patients in fact have access to the 18 atomic energy centers. It's a good news for the patient that the data I showed just now lacked the recent 10 linear accelerators that Atomic Energy Commission has acquired. Other centers may be at high-end technology like Chopper Khanum Hospital, Shifa Hospital, Northwest General Hospital, Gayatri Hospital in Karachi, SID, NCCI, but how many of our patients have got access to these centers? And very important image guidance, which I just showed the evidence on, may not be available at places where these patients are being managed. So we definitely need to realize what our patient have got access to and how we can improve as a team. So Pakistan is only surplus in terms of manpower for the medical physicists that we have, but still lag behind for the number of machines and radiation oncologists. But still in the region is catering to countries, neighboring countries like Afghanistan and Nepal. So radiation therapy treatment planning does not only require good machines or technology, but also merits the availability of manpower, the trained manpower who work in site-specific teams for betterment of the patient and correct methodology that allow the machine to be utilized best possible way. So we have already learned through the evidence Dr. Marco has just shared, and I shared few slides that these sarcomas need to be managed through site-specific team at Tertiary Care Hospital with all the facilities available who are talking to each other. The peer review of not only the radiation oncologist but other interdisciplinary peer review between the surgeon talking about resectability, reconstruction and all those systems, learning from each of our mistakes And we do not only need to develop radiation oncologists, but there is a learning curve for all the personnel involved in effective delivery of radiation treatment, which includes the medical physicist who is actually going to plan your patient, and the radiation therapy technologist, because the radiation oncologist only sees the patient once before starting treatment. At the end, when he's referring back to the primary surgeon, and maybe there's good system weekly during the course of treatment, but it's the radiation therapy technologist who is daily setting up the patient, talking to them and verifying what is being delivered, is it according to the initial plan or not. So at our center, we have a rate of about 22% changes in our treatment plan with what is done by a single radiation oncologist and the medical physicist. And this is agreeing to the international data for highly conformal treatment like stereotactic for the thoracic tumor. The number has been published to be up to 60%, with at least 23% being major changes in treatment plans. So what we need, I know this may not be of interest to the people present here because this is for childhood medulloblastoma, but not deviating away from the standard, but we definitely need to develop some local guideline or staying in the brackets of evidence-based medicine to have some risk-adapted regimens and treatment guidelines according to the resources that we have in the developing countries. So to conclude, I think that shall also be the take-home message for all of us, that for retroperitoneal sarcomas also we need to have site-specific teams. Thanks to Dr. Raza for putting up this program, inviting Dr. Marco, and I hope we can go a long way in the effort. The concept of peer review, not only for the radiation oncologists, but the business surgeons as well who deal with these tumors, making the conformal radiation treatment planning and good quality programs available to our patients, and this we hope that will be achievable through multidisciplinary teams. Thank you.
Thank you very much. I must appreciate Dr. Bilal, who is also very instrumental in setting up and running different MDTs and how it should be brought up. And in our discussion over the last 2 days, this came up that MDTs should have inherent learning in them, and it only can happen when all members contribute. So the clinicians talk to radiologists regarding their diagnosis and what they found in the surgery, and then pathologists talking to surgeons according to what they found, and oncologists and surgeons talking to each other. This should all happen in an MDT, and that's how the whole MDT process improves, and eventually patient outcomes improve based on these. And I thank you very much, Dr. Blatji.
So, thank you very much. I have two comments to the topic of radiation therapy that unfortunately so far all the evidences that we have, whether retrospective or prospective, are not randomized. So we have to think about the selection bias, because the patient who received radiation therapy were the one who were fit to receive radiation therapy. So size is an issue, and probably the patient who did not receive radiation therapy were the one with bigger tumors, and we know by the nomograms that size is also a risk factor. So we really wait for the randomized trial results. The other comment is that in this previous series that there is a lack of information about the standard surgical treatment. So they are very old series, and by the way, the occasion for putting together the transatlantic working sarcoma group was exactly this one. So to put a surgeon together, the surgeon who would have participated to the STRAS trial in order to have a standard decided surgical approach. and then we will randomize the radiation therapy. So we will wait this result both for the randomization and the standard modern surgical approach that maybe could also contribute to the local control.
So the same goes for Dr. Marco for radiation therapy, because it has been the previous database that I showed. Yeah, showed the patient from 1980s and 90s where cobalt was available when photons came into being, and now photons are being routinely used in those centers, and the use of intraoperative and high dose brachy during this treatment. So that goes side by side, and specifically when we talk about apart from retroperitoneal sarcoma, it's very well, because I do Ewing for the kids. It stands for Ewing as well, because it's a very radiosensitive tumor, but radiation therapy was once used as standard because it was radiosensitive, but surgery did not have good outcome because of the technique, and when the surgical techniques improved, the outcome for the safest surgery showed to be very good. So, but for the point that you mentioned, first of all, regarding who the patient goes to first of all. So we as a team have to come together and decide in the MDT what is best for the patient. But the thing is that in our part of the world, even for those qualifying for neoadjuvant radiation therapy, upfront may not be able to start in time. So that remains a big problem. If anything from chemotherapy is available, we are pushed to start on them. So that makes us use some optimal decisions.
Can I ask you if there's any possibility that perhaps proton beam might be better for this?
Yeah. I mean, you can tell, because that decreases the exit dose. The back peak, that high dose is delivered only to the tumor, and beyond that tumor, the dose falls.
So would it ideally be a good tumor to treat?
Conceptually, yes, but
I mean, because most of the times at the University of Florida, we put in the proton beam in Jacksonville, and so all the prostate people wanted to come. But it seems to me that this would be ideal for
retroperitoneal sarcoma is one of the.
Do you have any experience with that?
Yeah, I agree that the advantage of proton beam is the limited toxicity on critical structure. So we are routinely used, for example, for sacral chordoma or for spine chordoma, because you have the toxicity of the spinal cord. We actually have no experience on the retroperitoneal sarcoma. The Boston group is hardly working on this, but essentially the advantage could be to give the adequate dose with a mass that is close to, so it's not in terms of radiobiology, but it's in terms of the adequate dose close to critical structure.
This may be able to answer the question.
Just one more question. In your center, specifically in your center, are they using some regional hyperthermia followed by chemotherapy for the extremity sarcoma?
Yeah, we use hyperthermia with isolated limb perfusion. We don't have the facilities to give external hyperthermia like in the German protocol, also for the deep wave external hyperthermia. So we use hyperthermia only together with isolated limb perfusion. In that case, we use melphalan and TNF.
There is a trial that they have recommended it for the isolated limb perfusion. Rather than this isolated limb perfusion, first give the regional hyperthermia and then followed by the systemic chemotherapy with EIA, that is leukocyte, IBOS, and this Adria. And they show a very good result on that.
Yeah, okay, but this is not on the retroperitoneal tumors.
I think a huge credit goes to the transatlantic working group, because they were able to conceptualize and then able to design a trial, recruit completely on a rare tumor, whereas many of the multi-center trials which happen for more common cancers, they fail because of poor accrual. So there is a huge contribution of this working group to probably adding knowledge and opinion regarding the management of this. I think, thank you very much, Dr. Bilal. We will
May add one more point over here. I've rechecked it for the well-differentiated liposarcoma. They're saying that we don't need any biopsy for retroperitoneal. We don't need any biopsy for the well-differentiated liposarcoma.
How do you say it's well differentiated without biopsy?
So, sorry, I have to repeat once again that a biopsy is mandatory. This is a guideline statement. If you look at the consensus paper that we published within the Transatlantic Retroperitoneal Sarcoma Group, that is stated biopsy is mandatory. This is a message that should be spread out the community. The only exception, including in this consensus, is that if the radiology and the clinical history and the appearance of the patient is clearly related to a well-differentiated liposarcoma, within a multidisciplinary team discussion, you can decide to avoid the biopsy. But this could not be a message to the community. So you can avoid the biopsy if you decide within a multidisciplinary discussion that there is no other possibility and there is no other added information from a biopsy. But I would add, I don't know if this is an issue in Pakistan, but for example, I would take a biopsy anyway for my patient because we have also a problem with legal medicine. And if I have to consent a patient to such an aggressive disease, I need a robust information to offer this kind of treatment. So maybe this is not an issue here, but I mean, for whatever reason I get a complication, I mean, I was justified because that was a tumor. It was, so, well, this is not medicine, this is legal medicine, okay, but anyway, I think that the message is very, very important. So you cannot state that you can anyway operate because it will be probably or for sure a well-differentiated liposarcoma. But this could be a decision coming from a multidisciplinary discussion and justified by any particular reason for this specific patient, because to take a biopsy is really stupid and rapid and safe, and so well, you need a reason not to do it.
I think in the interest of time we will move to our last part, which is a discussion of cases. First, I will invite at least a panelist among at least the pathologist and the radiologist. So I will invite Dr. Nasiruddin and Dr. Fahad to please come and sit at the panel, and the rest of the clinicians can contribute from their own, from their setting, but I think we would require a contribution from the pathology and radiology in this respect. We quickly move on to cases in order to kind of look at things more conceptually. We have two cases. One is a primary retroperitoneal sarcoma and the other one is a recurrent one, and both liposarcomas, sorry for kind of not leaving the suspense, but anyway we'll talk about the management of these things. So the first case is a 50-year-old gentleman who had no pre-existing disease. He had abdominal distension, back on the long-standing excitation for 3-4 months, and he was worked up with initial ultrasound that showed a right-sided retroperitoneal mass. Now, questions: what imaging modality would you recommend for workup of suspected retroperitoneal sarcoma?
Well, I think what we usually have proceed with initially is a CT of the abdomen. I think CT remains the mainstay in the diagnosis of sarcomas. Yes, we can go for an MR, because it enhances the soft tissue contrast. So if you want to look at the involvement of the paraspinal muscles or the abdominal wall, that's where MR plays its role. But again, if you start with, I think CT should suffice.
For pelvis, maybe where you want to kind of
Yep.
assess resectability.
Absolutely. Pelvis, again, yes, MR plays a more fruitful role than CT in pelvis
Or
imaging.
perhaps in situations where a patient has a contrast allergy and cannot undergo CT scan. Those may be situations where MR. But Marco, are there any other particular areas where you would recommend MR in addition to or in place of CT?
In addition to CT, I agree with the involvement of the paraspinal region, the pelvic region.
Yeah.
I would add that the CT scan is also useful for complete staging, so you can extend to the lungs and you have stage condition.
For metastatic setting of the lung, you don't need even contrast for that. If you want to check for some medical node, definitely you have to put the contrast also. So if things are being MR being done or CT is being done for abdominal need contrast, for the lung is simple without contrast.
So to kind of summarize, in patients who have contrast allergy and have to undergo MR of the abdomen, they can have a non-contrast CT of the chest to stage the lungs.
True.
And we go to the input of this patient. So I will run this through. Sorry.
You want me to go come there and scroll down? Okay, I can scroll from here. Perfect. Right, this makes it easier. Right, so these are contrast enhanced exit sections taken from the lower thorax and the abdomen. So that's the liver. Now just along the inferior margin of the liver, you can see that the margins of the liver not look normal. There is scalloping, and this points us that this part of the fat is not the normal retroperitoneum, and that is the abnormal fat within the lesion that is causing scalloping of the liver margins. And then here you can see the solid component of the tumor which is pushing the kidney significantly anteriorly. There is significant loss of fat planes between the tumor and the kidney. Now the question which arises in the surgeon's mind is the kidney involved or not? Now, as a radiologist, we may be able to answer 9 out of 10 questions. Now, if there is no preserved fat plane, now what we can confidently tell you is that the tumor is definitely adherent to the kidney. But unless you see some infiltration in strands going into the kidney, we can't accurately comment if it's really going within the kidney itself. But these are important points which we need to put in the report, yes, that the kidney is significantly displaced and it's really abutting the kidney. Now that's the crust of the hemidiaphragm, the right crust. So the tumor is inseparable from the right crust of the diaphragm. You can see the renal vessels, that's the renal vein anteriorly. The renal artery again is abutting the tumor as well. Coming lower down, that's the aorta. So we have a fat plane preserved there. Now where is the inferior vena cava? That's the inferior cavernary right there. So you can see it's markedly attenuated, and that determines the irresectability as well. So that's where the surgeon needs to look out for. Coming lower down, this entire mass is put on the right side, the retroperitoneum, that's the ascending colon, again displaced significantly anteriorly, just below the abdominal vessels. That's the rectus abdominis right there. So even partially if you see that's the peritoneal lining, you can see that the tumor is not infiltrating into the abdominal muscles on the right. That's the psoas muscle right here, this triangular structure. So again, there is significant infiltration there into the psoas. Coming superiorly, that's the origin, as Dr. Marcos was saying. So at the origin side of the psoas, the tumor is adherent to it. So there is a strong possibility it could be infiltrating into the origin of the psoas.
What is the comment regarding the vena cava? Because whenever there is some bushing lesion, it appears like that. What we thought initially in cases that the cava is involved, but actually it was not involved. For the delivery and
Exactly, that's where I started my debate, was that in radiology you can't always accurately comment is there 100% involvement of the lesion or not. There are different signs or ways that we can depict, as in loss of fat planes, the attenuation, the compression, and the encasement of the vessels.
Sorry, if you have a question about the vena cava involvement, you don't have to ask the radiologist because he did his best. You have to ask to the pathologist.
So then we will take a biopsy. In case it will come up to be a leiomyosarcoma, then to be so close to the vena cava, the chance that the vena cava is the organ of origin is higher than 90%. Whatever is the radiological appearance, because leiomyosarcoma of the vena cava may be esophytic, so they can go outside vena cava or they can involve the lumen. But the answer about the vena cava is a matter of the diagnosis. If the biopsy will say it is a liposarcoma, then I will try to verify intraoperatively about the vena cava involvement. A priori, I think it will not be involved. Why? Okay. Because it's a liposarcoma. So the tumor is growing with pushing margins, and so it's only a matter of size of bulky disease, the chance to succeed in preparing the vena cava. But if the biopsy will be leiomyosarcoma, I will neither try to prepare the vena cava. I will resect and block.
Okay. Can you comment on this CT of the level of necrosis in this tumor?
But see, again, it depends from tumor to tumor. Looking at this huge chunk of tumor right there, that's the fat component. You can see there is enhancing areas here, which is predominantly solid. This again is solid with intervening areas of fat. So this tumor, these are the collateral or the neovascularity within tumor. These are markedly, vessels draining through the tumor. But if you want me to comment on necrosis, in this lesion, I don't see any definite areas of necrosis. Now, I may biopsy this lesion. The histopathology will say, I can see areas of necrosis there, but radiologically, all I can see is fat. I can see some relatively less enhancing areas which are solid and enhancing areas which are again solid as well. But within this tumor, in this particular patient, I do not see any different necrosis throughout the lesion.
Which area would you like target one big biopsy?
Exactly, that's a good question. Now you see, I would do a CT guided biopsy first and foremost. Secondly, I would go have a posterior approach because the tumor is in the retroperitoneum and that's a safe area to go from. Now, what I could target would be the posterior aspect of the tumor. I would not want to go too deep into the core of the lesion. I may have vessels there. But again, my intent should be to get a good biopsy, which is conclusive and would help the histopathologist and the surgeon to plan to assess what he or she is dealing with. So in this particular patient, I would go in, I think this looks like a good place to go in from. I think the length, if I measure the length from the skin, is about 9 centimeters. So like I said initially, the length of the spine needle is 9 centimeters. Maximum of most needles. So I could go say laterally and then go in an oblique manner, and if you see 9 centimeters, I'm well within the lesion. Again, that's not necessary. This again is retroperitoneum, so I could have a lateral approach from say somewhere here. So if I measure 9 centimeters, I'm well within the lesion. You see, almost within the center of the lesion. So I would opt for this enhancing area, the solid component, and then again take a core from a relatively fat containing part of the tumor as well. So 3-4 cores easily.
9 centimeters.
I think that's how they make it. Most needles are 9 centimeters. Yeah, that's a good question. I mean, makers, how they make it, usually 9 centimeters.
One of the issues when we advise biopsy for these patients, sometimes the targeted area is not achieved.
Absolutely, that's true.
They use the target report come after 2 weeks, nothing seen on this.
I know, I completely agree with that. See, it's again.
Maybe patients who have more of subcutaneous fat.
Is this a worldwide thing that you don't have a 9?
Well, I think I would say that this could be a limitation of a radiologist doing the biopsy. That's one reason. If I'm not well versed, if I'm not confident enough, if I do not have the expertise, I may not reach within the lesion. That's one. Second, yes, say for example a markedly obese patient has significant fat in the abdominal wall and the needle would not reach up to the tumor and probably say in the just outside the tumor. And I feel that I think I've done a good job, but the histopathologist says, you know what, there was nothing really in there.
with such needle, the chance not to be able to biopsy retroperitoneal mass is very, very low. So we can ask the industry to get 15 centimeter, but
make big needles.
so far it's good enough.
But some people are very big. Really, yeah.
Yes, they are, absolutely.
So what should be done then in the biopsy is not going to be too.
Sorry?
What should be done next to that? If the biopsy is the scale is not biopsy, but your lead is quite away from the 9 centimeter, then should we now go for the laparoscopic approach just if the biopsy is not?
Transperitorial biopsy.
Then 20 minutes.
If the 9 centimeters is not sufficient, you will have a biopsy just close to the solid part. Okay, and you will have anyway a diagnosis, and you can consider that could be downstaged according to the grade maybe. Okay, but you will have a diagnosis anyway. So if you perform a laparoscopic biopsy, you have violated the peritoneum.
Exactly.
Another problem that we see occasionally is there's pathologists who conclude that it is inconclusive, they're not able to tell us. So how many times it happens that we go for biopsy twice or thrice, but if repeated biopsy or of your listings or other is not convincing.
So if it is not conclusive, just repeat it second time.
Yeah.
If it is not conclusive, the second time, repeat it the third time. Exactly. So when there is usually a lipomatous lesion that are not expressing MDM2, it happens, so the pathologist is in trouble, but then at this stage just have an MDT, consider alternative diagnosis, differentials. For example, is it adrenal lesion? So we cannot, because we didn't consider the differential for the adrenal tumors, for example, benign or malignant. Otherwise, really it happens, and then you have to decide what to do. Surely, if you don't have a definitive diagnosis, you cannot hold for a cooperative treatment. So at that stage, you have to choose to go for surgery. But this is different than to decide not to take a biopsy. It's really, really different.
Yeah.
So is that extending and piercing to the umbilical canal?
Exactly. That caught my attention when I was going through this case earlier on. This was the interesting part, that if you would come down into the right inguinal region, you see that there's a hernia and the tumor is extending into the hernia.
Yeah, that was one of the clinical findings, that he had reducible inguinal hernia brought on by coughing.
It is not an inguinal hernia.
I'm sorry?
It is not inguinal hernia. It is tumor
It's
extending in inguinal canal.
Exactly.
Exactly. So again, this is one of the points that we will have to address in our surgical planning. Marco, how would you plan operation for this tumor? What structures would you suggest taking out?
So it depends on the diagnosis.
So we got a biopsy.
So please. Thank you.
I tried tricking you. Okay. We have the imaging, and then
So you ignore the spoiled parts.
should a biopsy be performed for this lesion? We have discussed pros and cons of biopsy. We've discussed the risk of needle tract sealing, so in interest of time we will move forward, and we've also addressed this question. And Nasruddin.
So, do you like
Well differentiated. So these are the multiple linear cores showing variable size adipocytes, and these are the scattered cells. Next, click. So on higher magnification, these cells exhibit multiple morphism, and these show positivity for P16 immunohistochemical stain. So in case if the biopsy showed only normal adipocytes and no atypical cells, then it needs to be repeated. So sometimes it happens the quantity of these atypical cells they are not, or they are very few. So it is difficult to make a diagnosis on one or two cells. So in that case, we ask for repeat. So fortunately, in this biopsy, there were plenty of cells. So we reported this as well-differentiated liposarcoma.
So, the atypical cells are also for lipoblasts?
No, these are called lipoblasts have different morphology. So those are large cells having cytoplasmic fatty vacuoles which indent the nucleus. So lipoblast is not required for the diagnosis of liposarcoma except the pleomorphic variant. So these atypical cells are sufficient because this express the immunosupplement markers of liposarcoma.
Now, Marcus, so now we have the diagnosis of a well-differentiated liposarcoma.
So now I understand that this is a liposarcoma. There's no evidence of the biopsy of a high-grade tumor. The radiologist didn't say anything about any critical issue about resectability. Actually, the tripod and the SMA is not involved. So I would ask the medical oncologist if there is any other reason to offer a progressive chemotherapy, but I don't think so because it's well differentiated tumor. I would discuss with the radiation oncologist whether there is any advantage expected by a preoperative treatment, but I expect the answer that is too big. It's extending the inguinal canal, it's overlapping the median lines, so the chance to irradiate also the contralateral kidney is there. So finally, I think we have to decide to go to the theater, and so we have to plan the extent of resection. So no discussion about the need to reserve the kidney because it's very close. No discussion about the need to reserve the colon because I need this margin in front of the tumor. No discussion about the need to reserve the psoas or to this part of the psoas because it's very close. And what should be considered in the preparative setting is what I expect on the vena cava. But I told you that now we know that it's a well-differentiated tumor, so I expect just that it will be hard to prepare the vena cava, but it will be feasible. So just a matter of time to dedicate to the preparation of the vena cava and to be on the safe path. So not to have a new incision. I would maybe consider to extend the incision laterally to have adequate safe control of the vena cava during the dissection. I think that the duodenum can be separated because it's a primary tumor, so it's a pushing growth, so I don't expect to need the resection of the duodenal but I will anyway consent the patient maybe for a partial resection, maybe not for a pancreatic but for a partial section of the duodenum. What I have to consider to consent the patient is for sure the orchiectomy that can be done with the laparotomy, or maybe if I cannot extract the tumoral part from the scrotum, I would have a contour incision in the inguinal region and preserve all the abdominal wall of the inguinal canal and block with the tumor. This will require a mesh reconstruction of the inguinal part. The other thing to consider, and the patient should be consented for this, is the resection of the diaphragm, posterior diaphragm, because we are very, very close to the cross, and so I think that the posterior part of the diaphragm will be an area to resect in this thoracic tube.
One more thing that although the truped biopsy reveals a well-differentiated liposarcoma, the radiological appearances are not so much for well-differentiated. Would you agree that this is more in line like a de-differentiated? Could this be a sclerosing liposarcoma, like you said, they're more from, maybe that's why it's appearing like this, like a de-differentiated?
part of this case sampling error, we might have gone because of all those concerns, let's say 9 centimeter, we will maybe gone just into the well differentiated component and not sampled it properly. So the middle core biopsy did not show the signals data. So it was a fatty tumor with skeletal cells. So it's not, but there are chances.
So provided the biopsy was taken as we planned, so we try to sample the most solid part, I will trust the pathologist. So it happens that also well-differentiated liposarcoma can be dishomogeneous with solid parts. It will not be completely well-differentiated lipoma-like liposarcoma can be sclerosing, but finally it will be a low grade. So, and then you told me that the patient is well, is alive, there's no symptoms, the diagnosis by chance, so there are no other reason to think about an aggressive disease.
So, like all our cases, we did discuss this case with Dr. Milan, and we were advised to take the kidney, abdominal, psoas, colon, as well as the right testis, and advised to see if we can separate it from the diaphragm. So this is the approach that we took. And
so hopefully we will agree with no?
Yes, more or less, except the diaphragm.
Except the diaphragm. I told you that I would have consented each.
Okay. So we discussed this question about the role of preoperative treatment and which situations would be amenable. Do you think if this would have been a high-grade de-differentiated liposarcoma pathology, would you consider preoperative chemo? Because that's how
I would have discussed with the medical oncologist. So
radiation currently, there's more of radiation on it.
So the STRAS 2 trial is actually, STRAS 1 included, please correct me if I'm wrong, so STRAS 1 included liposarcomas mainly low grade and intermediate grade, and did not include the de-differentiated liposarcomas. STRAS, yes.
No, any retroperitoneal sarcoma.
Okay, all retroperitoneal. But STRAS 2 is specifically targeting de-differentiated liposarcomas for potential preoperative.
So STRAS 2 is an idea. We are designing this new trial, and it will be a randomized trial for neoadjuvant chemotherapy for high-grade differentiated liposarcoma or high-grade leiomyosarcoma. We will offer different regimens, and we will try to randomize the high-grade to receive neoadjuvant chemotherapy. And we will correct the design of this new trial about the role of radiation therapy according to the expected result of STRAS 1. We don't know yet.
Can I ask, what is your normal time that you wait following? How much do you wait following preoperative radiation and preoperative chemo before you operate? In other words, once you give radiation.
After neoadjuvant chemotherapy, we wait 4 weeks, and that's the toxicity. I mean, the normal interval between the courses. And after radiation therapy, it's variable between 4 and 6 weeks.
So, like we see, this was a large tumor. This is, as we can probably guess from the umbilicus, that we have tilted the patient a little towards the left in order to be accessed posteriorly. And a picture on the operating field. We did a little laparoscopy. So this is head side, this is foot end. It's mainly retroperitoneal, pad-like mass, pushing the colon forward, and the mesocolon is covering the tissue. Without them, we were able to separate from the tumor. And same, and then following dissection of the colon and the ileum and mesocolon and mesentery to make sure that it is covering the tumor, as well as we were able to extract the testes from the laboratory
that lateral today. So I don't have pictures of all the operating steps because of not all the phases we were so cool and calm during this long surgery. But we can see that we have some muscle covering. Not all of this is psoas. This is some muscle on the lateral on the wall, and then we felt was close to the tumor. And then this is the lateral and posterior view. So some muscle we the tumor, some muscle addition to the tumor. And this is just to show that the extent of the incision of the this as well as the lateral slit going quite laterally. And the tumor itself, as you could expect from the imaging, was actually overhanging the midline. So it was not easy to get access to the pinna cava from this side. So we had to kind of walk our way from the IV planes and get into the adventitial plane, separate the adventitia so that the adventitia is covering the tumor and separating it from the IVC, and we will hope, quickly that we were able to achieve that plane and see the family going without any covering of the source in this case. And we have had to remove some of the lateral components. As we can see, some part of the diagram is visible here. Separate, there was, whole diagram of section that we prepared, but we want to present that. So for pathology, now this is a huge specimen of prognostically, and we sent it to you, and obviously we try and collaborate as a team after these go as well. So maybe next day or day after we get together and try and close this specimen together. But what are the considerations that we should keep in mind when sending this over to the pathologist, and just to make sure that the specimen is preserved and we can get all the information that we need?
So first is the fixation of the specimen, and this is a huge specimen, so it should be preserved in 10% buffer for in a large container. So we receive huge specimen put into small containers, so it distorts the specimen. The other consideration is that since this is a complex specimen, so margins should be in the sutures. Like in this case, Dr. Raza, he visited himself to orient the specimen, and we took the margins as he guided us.
Mark was telling about the approach and Curie Center, Dr. Bonvalo, who actually puts the tumor with pins, fixes along a board, and then describes the surrounding anatomy by diagram of the structures, and then marking all the important margins. So that's a very nice idea, which probably will help the pathologists as well.
Yeah, I have a picture. I was to us. It's just like a bubble of wooden or plastic, and you can put pins. But on the contrary, we are so lucky to have our pathology director. So we will bring immediately the specimen to the pathology gross specimen room. And I have to admit that the only aim to bring the specimen to the pathology is just to be sure that he will take some fresh tissue for tissue banking. So we always ask him. So I understand that if you receive in formalin or that is not possible anymore, or I mean not for frozen tissue.
Yes.
Yeah, not for culture or. Okay. So this is one other. Yeah, same corridor.
Well, I mean, I think the problem in Pakistan is you've got disparate areas where good people are doing work. So he's maybe doing great work here, and we are very lucky to have him in his team, really. But maybe the pathology of AKU and other places is better. So we've got this hodgepodge, and we have to work with it, I guess.
Yeah, okay, but I think you're doing a very good job, very good effort.
you cannot come to operate with Italy, Pakistani people, no? Okay, so you are in Pakistan, you are doing the best you can do. I think the effort to work together to create a multidisciplinary team is the most important thing. Then the logistics should be according to the local situation. And I am admired by your effort to try to improve the quality of care. I mean, we have problem in Italy as well. I mean, we are not perfect. So we are trying to improve ourselves as well. And so this is not the argument. The problem is you don't have to give up because this is a terrible disease. It's a rare disease. Outcome is poor. This is not true. You can really try to improve the quality of care, and whatever you can do is something for the patients. So.
Well, I say that because when Dr. Raza started work, he met me, right? And he was totally committed to big abdominal surgery. And he has pursued this in his place. And I think it is really, you're all to be commended because I think he spent time with you all. And I think it has really done the town a great deal of service because we used to in the past really give up on these cases, but not anymore.
Thank you very much. I think it's all about the team. Dr. Sami is here and he's partnering for all these complex cases. Anyway, so as we go along, we met Dr. Nasir and Pathology Lab at APU and we discussed. Now, do we see any areas of necrosis in this tumor compared to the radiology? What would you say right now?
Yes, it has some areas of necrosis.
But not predominantly, I would say. So perhaps the radiology read on the CT is as good as...
but it has some solid areas which could be the differentiated part. The yellow, well defined lipomatous part, and this solid one
would be the differentiated. And the kidney is lying here. Is that correct? Is this the kidney? I can't possibly tell, but maybe difficult to say. Or maybe this is the kidney. Yeah.
No, this is part of
my guess is that as any non-pathologist. So problems with trying to orient a fixed specimen informally that you so specifically recall looked so shiny and bright and tissues were able to differentiate. So you only encounter those problems when you try and orient a fixed specimen. And this is the reality that you can't figure out what it was, especially when it looks so different. Whenever you went to the pathologist and you took the specimen, the time you also made the specimen right? Yeah. So it's always good to mark every area that you've taken out, especially for tissues that are close together. Even if it's large bowel and small bowel, because once that specimen is fixed, in a complex specimen, you may be surprised you can't actually figure out things that you developed yourself. Anyway, so, and then we will go on to the pathology.
So this complex specimen was oriented by Dr. Raza, and it had a encapsulated tumor measured 26 into 21.5 into 7 centimeter. It was surrounding the kidney, and these were the representative sections taken. And histologically can show sharply demarcated, well differentiated areas and the more solid, more cellular areas. These cellular areas, solid areas on high power show atypical cells and up to 5 to 10 mitosis per 10 high power fields. So with a well differentiated area at adjacent to a solid, more cellular area, so no even ancillary studies are needed, and this was reported as dedifferentiated liposarcoma, and the designated resection margins were, the hepatic resection margin was less than 1 millimeter. In volume resection margin 1.2 centimeter. The tumor encased kidney but not involved the parenchyma. The bowel wall show ischemic changes, but it was tumor free.
Now, this is a normal practice with this well-differentiated liposarcoma, which we are seeing and doing is because there appears to be a capsule around the tumor, and the bowel usually is we can get the bowel pretty easily. So this is the issue basically which we have discussed whether to resect the bowel in that specimen or not.
So, but the idea of margin is we have to look at it differently from the margins in carcinomas that we see, the margin of involvement. But this is actually a margin of dissection that we have to create. So the whole mesocolon and mesentery of the small bowel in the right-sided regions is covering the anterior layer of the tumor. And the idea to have good local control is to take it out with its covering. And so the reason to resect the bowel is not because bowel is involved or not, it's because the mesocolon and the mesentery are kind of covering the tumor, and we want to take that covering of the tumor with it. Would you agree, Marco?
So this is the most common concern whenever we look in these cases, which appear to be encapsulated, not pushing, they're just pushing, not infiltrating anywhere, even differentiated sort of liposarcoma. So whether to resect the whole bowels with these specimen.
Yeah, but well, the plan is before you cannot then decide in the theater. I mean, you can decide if you have to perform a pancreatic duodenectomy or aortic resection. I mean, if the decision is whether to resect the colon, the source of the kidney, I will not try to decide on the laparoscopy because I mean, it is acceptable, and if you have a liposarcoma, then you will try to ameliorate the margin. So finally, is the differentiated liposarcoma. So I would ask at this stage to the pathologist to grade the differentiated part and be back to the multidisciplinary discussion whether it is a G3, the differentiated, maybe discussing with the medical oncologist if at this stage you would consider some more adjuvant treatment.
We have to confirm whether it's a G1, G2 or G3.
In this it was G2.
It's G2, then definitely with G2, it's a T4 lesion, it's 26 centimeters.
26 centimeters.
T4, G, M naught is a grade 2 lesion, stage 2 lesion. The stage 2 lesion with R1, will you say R1 or not? Less than 1 mm.
So staging with TNM is not so accurate for retroperitoneal sarcoma. In the last edition of the GCC system, the nomogram has been included to evaluate the risk of patient with retroperitoneal sarcoma. So if you have a smartphone, you can try to calculate the risk for this patient. Where is it? So circulator. So I set all term and conditions. So this is a primary RPS. Age was 50, right? The tumor diameter, maximum tumor diameter, 26?
26.
26. You told me it is a grade 2. They differentiated liposarcoma. There was no grade 2. Okay. They differentiated liposarcoma, no multifocality, and complete resection, correct? So calculate. So the 7-year overall survival is expected to be 61%, and the 7-year disease-free survival is 37%.
So what's the stage?
No matter what is the stage. The stage is not accurate to calculate the risk of this patient. So this is the last edition of the JCC. Eighth edition.
There's a
8th edition.
8th edition in
they separated the retroperitoneal sarcoma and they included the nomogram as the better instrument. Yes.
So we can discuss. Anyway, so we can. Mentioned hepatic infection margin as a one variable. We have said that we did not do it accurately. We just kind of took it off the liver, and then we will accept that in areas where we could. Because you can in situations where you can consider capsulectomy. These are situations, but like we discussed, taking saying complete resection macroscopically, as in a close complete resection, is what makes a difference to the outcome. So we can accept R1 inside certain areas, but yes, you're right. This is probably one situation where capsulectomy would have resulted in complete resection. But so this is macroscopically a complete resection because we can have a look at the tumor bed of the dissection. And that's what tells us that this has been completely incised.
How much bleeding do you encounter in general? It doesn't look like much.
In this situation, or
in this, how much did you?
Well, we had been lucky in this situation that we did not encounter a lot of. When should we have given chemo in this case?
Well, you know, the dedifferentiated sarcomas are not very sensitive to chemo. I think that chemotherapy has always been a hope, but half the time we ourselves really are afraid of what it will do. And having said that, I think the role of adjuvant treatment is best in the extremity sarcomas, right? And that's been done by the Italians mainly. So I'm not so sure that I would be really up to giving adjuvant chemotherapy.
If you're going to grant for adjuvant chemo, it's only for R2 resection, when resection is not possible. For R1 and R0, you have to give plus minus radiation if it's feasible, not chemo. Chemo means if you're going to give chemo after the surgery, it means R2 section where resection is not possible.
So quick question, Dr. So hepatic resection margin was less than 1 millimeter away. Would it have made a difference if we did a capsulectomy of that area?
So the idea is to minimize the marginality. Okay, so it was a huge mass. The margin on the liver is not the major one. I mean, less than 1 centimeter is not positive margin, it's minimal margins.
Yeah. The margin is also the maximum achieved margin.
So, I think it's a well-done procedure. I would have not done differently. And probably in our center at this stage we will decide only to follow up the patient, so not to give radiation therapy because, well, there's not really a critical point. There was a very huge mass that was going on the other side. We have no evidences that the metastatic risk is so high to offer an adjuvant treatment, so we would follow up with this patient for 10 years. For the first 2 years very closely, every 3-4 months with CT scan, abdominal CT scan, and after the second year every 6 months, after the 5 year every 12 months.
So we cannot radiotherapy boost the necrophagy, so there is no evidence of radiating only the partial liver capsule area. If a patient qualified for radiation therapy, we have to irradiate whole of the tumor bed, and that's not possible in the care with but whole of the abdomen going into the inguinal canal, it could be very toxic treatment to give therapeutic dose for R1 resection, 66 grade, and even boosting that area 66 grade, that area with the small bowel, liver, pancreas, vessel nearby, the upper bowl of the kidney, that's not practically possible.
So
that the dilemma with offering activate radiation because you are not able to give adequate dose to that area. It's better to observe and there is no evidence in boosting an area of R1 resection. Yes, there are studies where, and the recommendation is for high grade or explicit grade tumor where you
that we calculate the risk. So you have an overall survival of 60%, but a disease-free survival of 37%. So it means that this patient is likely to recur in the future. So you don't have any evidence that today, as an adjuvant, you give an advantage of the radiation therapy, but maybe it could be useful as multidisciplinary management for the recurrence. So I would not offer radiation therapy today, but in case of local recurrence, maybe it will be discussed as a preparative treatment or as a definitive treatment for symptomatic recurrence close to the spine or whatever, or inoperable disease or symptomatic.
So I wanted to ask you, you said in your talk that we shouldn't think of the R basis for resections. You know, the R1s, the R2s. Yeah, so we shouldn't. And yet, so in other words, once you resected them, how do you like to think of them in terms of what should be done in the future? Is it that the margins are close? Is it that, in other words, you don't want to use the term R that is being...
Yeah, exactly. So what matters to me if it has been resected completely or not.
Yes.
If not, this is a big problem. So if not, it depends why. Because the surgeon was not aware of the diagnosis, because it was irresectable. So which is the diagnosis? Because I found unexpectedly intraperitoneal disease that was not resectable. So there are different reasons to have an R2. Okay, so if I have an R2, I have to decide what to do. But if I have a complete resection, then the problem is just about the metastatic risk or the risk of local recurrence, but I've already discussed before surgery.
So in the interest of time, we move on to the next case that we will discuss quickly. This is a 35-year-old female with no existing illness. She had previously been operated twice for a recurrent retroperitoneal mass, and her last resection was in March 2016. And we will just show the histopathology report at that time that it showed, wherever this was reported, it showed a similar morphology. There's dominant chicken wire vasculature, multiple scattered fluoride-like multinuclear time cells, and no condenses and no pre-collagen bundles. Lesion does not exhibit circumscription, and they're positive on IC for CT34. They concluded that this is a features favoring myxoid liposarcoma and with a pleomorphic lipoma as a differential diagnosis. With this diagnosis, she was followed up, and in May 2017, she developed a recurrence, and this was evaluated on CT scan and advised further excision. We do not have imaging for a second for this recurrence available, but if we feel that this recurrence is resectable, should we obtain a biopsy before planning excision? Because again, we discussed that it may change, the differentiation might change.
I would not ask for a biopsy, but this is a 35 female, so it's very young. The diagnosis of myxoid liposarcoma is quite unusual. We told you in the talk before. So I would ask for the previous slides and review the previous slides and ask for a molecular analysis. If it is really a myxoid liposarcoma, the translocation should be there. And then, if it is a myxoid liposarcoma, I will stage the lady for an adverted primary elsewhere in the extremity. So this is will be a metastatic patient. But most likely, I would expect that the second opinion on the previous slides would have concluded from the differentiated part of the differentiated liposarcoma with myxoid components. So with no evidence of translocation. So in this case, I have only a patient with a multi-recurrent retroperitoneal differentiated sarcoma. I don't know if persistent or genetically operated or really recurrent. So unfortunately, this is a very bad presentation, and I would offer the best surgery I can offer. The planning is not anymore the one of extended multidisciplinary, because we are in a palliative setting, I would say, because the patient is not cured. So the aim of surgery would be simply the complete resection of all the evident tumor, and in case if it is needed for technical reason, resection of the surrounding organs, but not as a priori statement and philosophical and with no doubt decision. Okay.
So this was resected as well, this recurrence, and this happened in May 2017. And on operative finding, it was found that the mass is along the right source, lifting the kidney upward, casing the right ureter. Preservation was attempted by dissecting the ureter free, and the mass was shaved off the source, separated from the kidney, but it was removed in one piece. And the biopsy, this was shown as a single irregular nodular light yellow soft tissue piece that measured 19 maximum centimeter. Outer surface is inked, cut surface is pale yellow. Microscopy reveals variable sized nodules and sheeting architecture, scattered lipoblasts showing well-defined cytoplasmic border with vacuolated cytoplasm, centrifugated hyperchromatic indented nuclei. Mitotic activity was seen. Intervening tissue shows inflammatory infiltrate, thin chicken wire blood vessels, no mixed oily areas are present on multiple sections examined, and they concluded this is a liposarcoma compatible with recurrence, and size was 19 centimeters. They have not mentioned any margins.
No matter. No matter what happens.
And are we happy with just mentioning liposarcoma, or do we need more detail for this?
What would you say on this?
Type should be mentioned, which type of liposarcoma.
Yeah, because we are not sure about the diagnosis of mixed site. So,
Yes, they mentioned that all the areas are kind of
sorry?
They say no mixed soil areas are
Yep.
I think what this highlights is that all pathology for these tumors should go to, say, areas who are people who are kind of interested. Because otherwise, in the general pathology unit, they will be reported exactly like this. They will say, okay, fine, I told you it's a liposarcoma, what more do you need? And because of the reason that they are probably not interested. Would you agree? I think that it would have been a different report if we had sent it to you for that you would have been able to form comments on necrosis, mitotic figures, grade, and so on and so forth.
Yeah, I would say that liposarcoma is not sufficient. I mean, the well-differentiated liposarcoma, they differentiated liposarcoma are subtypes of the same disease. Mixed soil liposarcoma is a different disease. Different etiology, different pathophysiology, different molecular features, and different treatment options. So I would gently ask at least to state whether it is a mixed soil or not. And then, if it is differentiated, maybe some more information about the aggressiveness of the disease to help the medical oncologist to figure out whether anything is more needed for this patient or not. And just remember, because if it were a mixed soil, I am obliged to stage the patient on the limbs.
So would you do a PET-CT or just examine what if you look for the primary?
If it were a mixed lipo, well, a physical examination, and then, well, sometimes we ask for a full body MRI, but I mean, if you find a diagnosis of mixed liposarcoma in the abdomen, then the primary is pretty evident if you look for that, even any examination.
So this again, this patient was followed up, and so question about preserving the kidney, especially when it was encasing the ureter. Would
recurrence.
Yeah, absolutely, yes.
Would you agree that the kidney should be preserved, or should we take it out?
Absolutely, yes, because with a first surgery, you have no chance to ameliorate the prognosis with a extended resection. So, what I present you before is the standard treatment for primary tumor, not for recurrence.
So on follow-up imaging, this in one of the mouse.
Please.
And I'll just quickly run through this. So this was 3 months down the line, and oh, sorry, this is yeah, three months down the line. This is September 2008. So from second surgery, and any abnormalities that you would want to report on this?
Yeah, I mean,
3 months down the line, and this is the section in which the kidney inheritors were preserved.
I mean, looking at this area right here, I mean, I see some fats trending there, just interior to the sauce. Now, I don't see any discrete lesion. This could be just post-operative change. How long after the surgery was this? After 3 months. Well, again, this could be suspicious. I mean,
So apart from that, there are no.
I mean, I don't see any discrete lesion there.
Can you just scroll down the rest of the images? There are no on the left panel. So. So now we are almost 10 months down the line.
Right, so this is the, I mean, here, just medial to the kidney, in between the kidney and the sauce, there's definitely a lesion right there. There's a lesion there. I mean, it predominantly is fat, but now if you compare the width of the right sauce muscle, it appears attenuated as compared to the left. So this tells me that there is something there. This doesn't look like normal fat to me.
Probably swabs have been taken out previously and not actually increasing, but
Look at the IVC there. You can see that the IVC just above it looks normal in caliber. As I come down caudally, it appears slit-like. So I think
If
this.
you compare the fat medial to the kidney on the left side,
Yeah.
this is different.
Exactly. I mean, the kidney should always be invariably next to the sauce. There shouldn't be any gap in between. So this tells us that, you know, that's the margin of the lesion there. This white rim. I hope that's evident on the scan. Let me magnify it, if I may. That's the margin right there. And that's the posterior margin of the lesion.
So we don't need the translocation anymore. Because this is a well differentiated
Yeah,
point
yeah.
of the differentiated sarcomas.
So this time again, so in the interest of my time, move on. So this is a recurrence which radiologically looks well differentiated.
Well differentiated.
And based on this, we went ahead, discussed this again with the team in Milan. We were advised on Dr. section to remove the kidney ureter, and the source. This was performed on the right side, but in addition, multiple lateral lesions were found in the mesocolon of the sigmoid. Some of these were taken out, but there were still residual lesions left behind. And you know, when we were performing the surgery,
we were arguing if we can take the whole of this fab out, it was kind of impossible. So we took out whatever we could and left it at that to see how things go beyond that, and then sent it for pathology.
So grossly multiple circumscribed nodular lipomatous tumors were seen, and the largest was 8 into 7 centimeter, which was adherent to kidney. So multiple representative sections were submitted, and this is the microscopic low power view in which a well differentiated adipocytic tumor is seen with variable size adipocytes and fibrous septi. And these fibrous septi showed scattered atypical stromal cells and lipoblasts. No solid area was seen grossly, and the differentiated part histologically. So this was reported as well-differentiated liposarcoma, and the largest nodule size was 8 into 7 centimeter, and the margins were I guess this was the bowel margins were free, and renal parenchyma was uninvolved by tumor.
It says total 12 lymph nodes.
12 lymph nodes and all were tumor free.
So multifocal recurrent liposarcoma, well differentiated. What would the circulator tell us about this? Incompletely excites because we have left
I expect it will be a disaster. So age now is 37. Grade 1, well differentiated. Multifocality at second surgery, so this is even before surgery. Okay, yes, incomplete resection. Chemotherapy for primary tumor, no, because this is in radiation therapy for primary tumor, so we have a different nomogram for the recurrent disease. Number of organ resected at this surgery. Adrenal is not the count if you resect with the so kidney and adrenal is one organ in this nomogram.
Kidney and
Colon. Calculate. So 6-year overall survival from the second surgery is 43%. And this is well differentiated liposarcoma, so at the beginning probably would be much more. And 6-year disease-free survival from second surgery.
And on 4 10%, 3%,
6. www.circulator.com. You can download the Circulator. These are advertising, but I disclose I have any conflict of interest. Download for free, it's for the community. So.
No financial disclosure.
As I said, and when you come across such cases, which is common in our part of the world, the choice of extent of surgery in third case and fourth, the third time when the patient was operated, organ preservation was done, versus that fourth time we went ahead for colon and kidney section. It was done after MDT discussion, but do you think now retrospectively looking at it, should we have gone for this further resection at fourth surgery or?
Yeah, I understand your question, but so I understand this is a young lady and she received for 3 times inadequate surgery without any, let's say, oncological strategy. So for such a young lady, I could give her at least 1 try to receive more extensive surgery, even if the data I presented you is for minor disease. But actually in this situation, she had a well-differentiated tumor that was exactly behind the kidney. And the well-differentiated component is not distinguished. You cannot distinguish from the peritoneal fat, and then you should also consider that you have to prepare for the 3rd time you repair. So finally, I mean, overall the kidney, I think it should have been resected anyway. For the colon, okay, I agree. Maybe it's not the standard, but I mean, it's just to give her a try at least once during the history of this disease. And it's not morbid, like the colectomy for a young lady, but it will be morbid the next recurrence. So.
Do you think that the peritoneal spillage in the first few times is the reason why there are so many multiple?
I think yes, but you cannot demonstrate this post-hoc. And moreover, the pattern of local relapse that is described in the paper of the cardiology group, the pattern of local relapse frequently shows that you have maybe a retroperitoneal liposarcoma, you treat with extended surgery, and by chance I cannot explain why it will occur on the left side, maybe on the left retroperitoneal space, so contralateral. It does not be touched during surgery, it has been not contaminated. So this is, I cannot explain you. There's some hypothesis that all the fat is a sort of locus that is prone to develop the pulmonous tumor. But we observe also intraperitoneal relapse, even in case of complete and non-contaminated surgery. So for this case, it could be the case of contamination, previous contamination, but it's a sort of pattern of relapse. Rarely you can find intraperitoneal nodules also in primary cases, or intraperitoneal invasion of the retroperitoneal muscle is going beyond the mesentery, is invading the peritoneal surface of the mesentery, and we consider this as an adding risk factor for recurrence. Because the tumor is no more limited to the retroperitoneal space. So this is the reason not to give laparoscopic biopsy, the reason not to give contaminated surgery. So.
Yeah, I think the first case, you said that there was an incomplete surgery. The first case, not the second one, where you said the lymph node has not been affected. So you will say it's incomplete surgery, and in this calculator you're going to put an incomplete.
Mostly the whole tumor has been taken out.
So you will say node has not been affected, it's a complete or incomplete.
Lymph nodes. Which lymph nodes?
In the first case, primary retroperitoneal sarcoma, 26 centimeter, age was 56 of the age, and when you put all this your data, you calculate the survival of roughly 7 years survival, 6 years survival of roughly 60-70%. You said that it's not a complete surgery because nodal resection has not been done.
No. I told you that in liposarcoma, in sarcoma in general, in retroperitoneal tumors and retroperitoneal liposarcoma, you do not expect to have nodal metastasis at any time of the history. So you don't need nodal possession, and you cannot use the TNM staging system because the TMs, the staging system is tumor, nodes, and metastasis.
Yeah.
So over 3 criteria, there is a not meaningful one. That's node involvement is adequate for epithelial tumors for carcinoma, but it's not adequate to evaluate to stage the risk of sarcomas in general. That's why in the last edition, retroperitoneal tumors are staged according to the nomogram.
So when we say complete, it's grossly complete excision of tumor, right? So thank you very much. Thank you all for coming and staying this long. And this very interesting and interactive discussion. Thank you very much. I would like to thank the sponsors, Roche company, who kind of generously supported us, and I would also like to extend gratitude to the IT team for Patel Hospital, and as well as the technical support from Infosys Pakistan, kind of arranged all the live streaming and recording, and hopefully this will be a regular feature for all Patel CME activities. This will be available to watch on our YouTube channel, which is Patel CME. Infosys Pakistan can be accessed at www.infosyspark.net, infosyspark.net, in case you want any questions regarding how to technically organize this. Thank you very much. This has been a great session. Thank you very much. This is a good addition that you have given this software. I think one ये काम मुझे नहीं आता है करने इसलिए but you didn't show software I'll put this software
there's no substitute for that. A lot of cases like